Ωραία. Όποτε είναι, μου λέτε να ξεκινήσουμε. Ξεκινάω. Ωραία. Ωραία. Dear colleagues, good afternoon and welcome to our workshop on best practices and tips in nuclear medicine. First of all, I would like to express my sincere gratitude to GE Healthcare for organizing this event and for their generous support in covering it. I also wish to extend my thanks to all our distinguished speakers for taking time of their busy schedules to share their expertise with us, as well as to our session chairs for skillfully moderating the roundtables. Finally, a very warm welcome to all of you joining us today, whether you are here in person at the Amalia Hotel in Athens or following the live stream remotely. Your presence and engagement are what make this gathering truly meaningful. Wishing us all a productive and insightful session ahead. Now I would like my co-chair, Dr. Datseris, please.
I'm very pleased being with you this hot afternoon in the center of Athens. It's a very nice venue, as I realized. It's my first time in this hotel. It's a very interesting choice. And also, I think that the organizers, Yannis Koutsikos and the G Health staff, selected a very interesting topic about concerning the current status, scientific status of nuclear medicine, and the spotlight are very, very efficient, focused on things, on fields that are in the scientific and daily practice front line. So with no more speak from us, we can start. Yeah.
So we can start now with our first session regarding theranostics. So it is a pleasure for me to introduce our next speaker, Dr. Das, Dr. Speg Das. He is coming from India. He is Associate Director and Head of the Center for Nuclear Medicine and Molecular Theranostics at Sarvodaya Hospital in Delhi, India. He is a nuclear medicine physician with expertise in molecular imaging, radiotheranostics, and advanced radionuclide therapies. His clinical and research interests include PSMA, FAP, and the somatostatin receptor targeted theranostics, with a particular focus on next-generation radionuclides such as terbium and actinium. Dr. Das has contributed to several national and international scientific publications, and he is actively involved in advancing precision oncology through radiopharmaceutical development, translational research, and clinical implementation of theranostic strategies. He's going to discuss about FAPI because, as we all know, conventional FTG has some limitations in tumors, particularly in tumors with low glycolytic activity or high physiological brain uptake. On the other hand, FAPI, by targeting fibroblast activation protein, offers a shift illuminating the tumor microenvironmental with exceptional contrast and low background noise. Dr. Das will walk us through its clinical applications from improved tumor staging to its growing role in theranostics. Dr. Das will, here is with a pre-recorded speak. So if some of us has several questions or would like to discuss something, he can send to the organizers an email. We will forward this to Dr. Das and we will have following the answers. So let's have the first pre-recorded speaker, please.
Very good morning, everyone. Myself, Dr. Swagat Das, and I am from India. At the outset, I would like to thank Professor John to allow me to speak on my FAPI experience. My topic of presentation is the FAPI shift rethinking PET beyond glucose metabolism. So if we look at the history of FAPI PET, the comprehensive publication was this one that was published in JNM March 2019 by Heidelberg Group. This was featured as the featured article of the month. They showed FAPI tracer uptake in 28 different kind of cancers. And finally, that was published as image of the month in June 2019 in Journal of Nuclear Medicine. So we will be talking on FAPI PET on these topics like FDG PET, what are the pitfalls and shortcomings, what are the FAP inhibitors that we use, clinical implication, myth and facts, case-based discussion on FAPI and FDG, and imaging pearls and pitfalls. Conclusion. I have nothing to disclose. So to look at the FDG PET, this is the diagnostic workhorse in oncological imaging. We have the experience of more than 25 years of PET-CT. All the international guidelines and recommendations are based on FDG PET-CT. It has favorable radiopharmaceutical characteristics, wide availability, and cost effectiveness. So we have decades of evidence, global guidelines, and broad access. So that's why FDG PET remains the gold standard in oncological imaging. However, there are certain limitations with FDG PET. It is relatively non-specific radiotracer because we have seen uptake of FDG in non-cancerous cells like inflammatory lesions, infections. It becomes at times very difficult to differentiate between malignancy and whether the lesion is infective or inflammatory. It has high physiological uptake in brain, GI tract, and GU tract. So the lesions in these areas, they may get obscured. Radioactive glucose analog it is, so we need strict fasting, and fasting blood sugar should be within normal range. And there are certain interaction like insulin, corticosteroid, they may alter the biodistribution. So understanding this limitation and preparing the patients appropriately enhance the accuracy and clinical value of FDG PET imaging. So because of these limitations, we are always looking for any alternative radiotracer. And next comes the FAPI, that is fibroblast activated protein inhibitor. So prior to talking on FAPI, we need to understand what is the tumor microenvironment, that is TME. TME comprises of cancer cells, cancer-associated fibroblasts, immune cells, extracellular matrix, endothelial cells and vasculatures, soluble factors, and other stromal cells. So what is FAP? FAP is fibroblast activated protein, which is a cell surface serine protease highly expressed on activated fibroblast in tumor stroma, but minimal in most of the normal adult tissue. It is highly expressed in more than 90% of solid tumors, limited expression in most of the normal tissue, and it can be an excellent target for imaging and therapy. So take-home message is TME is dynamic and an interactive ecosystem. FAP expressed in cancer-associated fibroblast is a validated and highly attractive target in theranostics in oncology. So now the overview of FAPI. As you can see, this is the FAP structure. It has a large extracellular domain and short intracellular domain with single transmembrane region. Fibroblast activated protein is a short, it is a 760 amino acid type 2 transmembrane glycoprotein, predominantly expressed by cancer-associated fibroblasts. These cancer-associated fibroblasts are involved in remodeling of tumor microenvironment. So activation triggered by tumor stressors like hypoxia and oxidative stress. Upregulation of surface marker becomes in these tumor-associated stressors. So this FAPI, they become regulated, FAPI expression become upregulated, making it a promising target in precision oncology. This is the schematic diagram, how it happens. As you can see, this is the FAP inhibitor protein. On one end, it attaches to the Fab receptor extracellular component, and in other end it may be attached to a diagnostic radioisotope, so we can have SPECT or SPECT imaging, or a therapeutic radioisotope where you can treat the patient. So now coming to why Fab targeted imaging is attractive, because the tumor lesions exceeding 1 to 2 millimeter in size, they require formation of a supporting stroma. And stromal volume can be larger than the cancer cell volume. That's why as stromal volume can be larger than the cancer cell volume, the stroma targeted PET imaging may be more sensitive than glucose metabolic PET imaging for detecting small lesions if FAP is expressed sufficiently. FAP targeted PET imaging may also be attractive for detecting tumor lesions with low or heterogeneous glucose metabolism, or those located in close vicinity to highly glycolytic normal tissue. Early imaging is possible at 10 minutes, and because there is absence of required fasting, that simplify our workflow and improve patient convenience. These are the normal images of FAPI PET. We regularly use FAP46. So physiological uptake, we can see in muscles, oral mucosa, low-grade thyroid uptake. There may be salivary gland uptake, then diffuse pancreatic uptake. This is also a physiological activity, and low-grade or high-grade uterine activity we can see. And as usual, it is because it is being excreted by the renal system, so we can see renal pelvis and urinary bladder activity as well. These are most of the common cancers. It has been shown that they show very high FAPI uptake. As you can see, renal cell carcinoma on one end and carcinoma of unknown primary on another end. So most of the cancers, they show FAPI avidity more than the blood pool activity. That's why it is a very interesting radioisotope to be explored in most of the cancers. There are a host of applications on role of FAPI PET in oncological imaging, and because of this, we are evaluating FAPI in most of the cancers. I will be dividing my talk into three parts. The malignancies will show low FDG avidity, malignancies will shows intermediate FDG avidity or high FDG avidity, and how does FAPI PET behaves in those malignancies. So starting with tumors with low FDG uptake. Number one is thyroid. We all nuclear medicine physicians are very interested about thyroid. So first is tennis syndrome and radioiodine refractory differentiated thyroid cancer. SUV max of the lesions detected on FAPI, they are higher than FDG in metastatic lateral compartment, axillary, mediastinal lymph nodes, and pulmonary metastasis. FAPI PET has high sensitivity than FDG for depicting neck lesions and distant metastasis. FAPI is better than FDG for depicting metastatic differentiated thyroid cancer. FAPI SUV max is more than FDG in most of the metastatic lesions, and FAPI has higher sensitivity for depicting neck lesions and distant metastasis. Now coming to hepatobiliary malignancies, FAPI has better sensitivity, specificity, accuracy for diagnosis of primary disease. It can differentiate hepatocellular carcinoma from benign non-inflammatory focal liver lesions. Nodal and metastatic staging better delineated on FAPI PET. For cholangiocarcinoma, FAPI is better for TNM staging and higher sensitivity for inflammatory processes secondary to tumor-related obstruction. So now this is a case. Patient presented with obstructive jaundice, and the indication for PET scan was diagnosis and pretreatment staging. The patient had hilar cholangiocarcinoma. As you can see on FDG PET on your left side, there is intrahepatic biliary radical dilatation, and there is a stricture which is non-FDG avid at the primary biliary confluence. But when you look at the FAPI PET image, that stricture is FAPI avid. So this is hilar cholangiocarcinoma, FDG negative, and FAPI positive. This is another case, again, presented with obstructive jaundice, suspected periampullary carcinoma for diagnosis and staging. As you can see on FDG PET, the lesions are mildly FDG avid, but on FAPI PET, as you can see, the lesion is highly FAPI avid, but associated with that, there was cholangitis and pancreatitis. All are FAPI avid as well. This is a case of post-laparoscopic cholecystectomy with epigastric mass and omental thickening. So FDG PET shows very low FDG avid epigastric mass and omental thickening showing very low FDG uptake. But on FAPI PET, see the epigastric mass and the omental disease. So this is a missed carcinoma gallbladder with port site metastasis and secondary peritoneal carcinomatosis, very well depicted on FAPI PET rather than FDG PET. Now coming on to peritoneal carcinomatosis, FAPI has very low non-specific uptake in peritoneal cavity, so it has superior sensitivity compared to FDG PET in both quantitative and visual evaluation. Better delineation of disease burden, and it has clinical impact in PCI scoring, and it can facilitate surgical planning. This is a case of carcinoma ovary with secondary peritoneal carcinomatosis. And you see on your left side, these are FDG PET images. And on your right side, these are FAPI PET images. FAPI PET beautifully shows the burden of the disease more clearly than FDG PET. In prostate, FAPI is comparable with FDG for staging across all Gleason scores. No obvious advantage in biochemical recurrence. PSMA PET still remains the best PET. For soft tissue sarcoma, FAPI has significantly higher sensitivity, specificity, accuracy for diagnosis of recurrent lesion. Now coming into tumors with variable FDG uptake. Number one is breast. FAPI has higher accuracy in tumor and nodal staging. No significant difference in FAPI uptake of primary tumor across different grades, receptor status, or histologic types. Lobular carcinoma, we all know this is none or very low FDG avid. Triple negative breast cancer can be tricky with FDG PET and M staging. So when we go for lesion-based analysis, FAPI is better for pleural and brain metastasis. And on patient-based analysis, FAPI is almost equivalent to FDG. This is a case of lobular carcinoma right breast pre-treatment staging, PET CT scan. This is the FDG PET. As you can see, right breast lesion, very minimal FDG uptake. But when we look at the FAPI PET images, that right breast lesion is very well visualized on FAPI PET. But apart from that, contralateral breast has also another lesion which is visualized on FAPI PET, but hardly visualized on FDG PET. So if we don't know the history, we may miss the lesion on contralateral breast if we are doing only FDG PET. Now coming on to gynecological malignancies, FAPI has higher accuracy in TNM staging of carcinoma ovary, as I have already shown, impact on treatment strategies, and helps identify suitable candidates for surgery. It has better sensitivity, specificity, positive predictive value, and negative predictive value in biochemical recurrence. Carcinoma, endometrium, and cervix, FDG may be better because FAPI can have physiologically high uptake in endometrium or cervix. So this is a case of carcinoma endometrium with secondary peritoneal carcinomatosis. On your left side, these are FDG PET images, and on your right side, this is FAPI PET. So you can see the endometrial mass is FDG avid as well as FAPI avid, but the burden of peritoneal disease is very well visualized on on FAPI PET rather than FDG PET. This is a case of carcinoma cervix, N0M0 disease clinically. But when we look at the FDG PET images, the lesion is very small in cervix and very mildly FDG avid, whereas on FAPI PET, the lesion is very well shown and highly FAPI avid, difficult to miss. Now coming on to gastric, adenocarcinoma for T staging, FAPI is better than FDG. For N staging, sensitivity of FAPI is more than FDG. Specificity is comparable. Again, for M staging, sensitivity of FAPI is more than FDG, but specificity is comparable. However, for signet rim cell carcinoma of stomach, FAPI outperforms FDG across all parameters. This is a recently diagnosed poorly differentiated gastric adenocarcinoma sent for PET scan for pre-treatment staging. And as you can see, the primary lesion very mildly FDG avid on FDG PET, and the node is hardly FDG avid. Whereas on FAPI PET, the primary lesion shows excellent uptake of FAPI, and the node is also mildly FAPI avid. Now coming on to neuro-oncology, primary brain tumor assessment, prognostication, brain metastasis detection, tumor volume delineation and radiotherapy planning, tumor surgical resection margins and completeness, biopsy guidance, suspicious recurrent assessment, and for theranostics. Definitely FAPI outperforms FDG because in brain, FDG has very high physiological uptake. So at times, it becomes very difficult to interpret FDG images across all these indications. So this is a paper which evaluated FAPI versus FDG in GBM, that is glioblastoma multiforme before radiotherapy. So it concluded that FAPI PET has lower sensitivity than MRI. However, there is 100% positive predictive value of FAPI. And this is the theranostics of GBM. Patient underwent 2 treatment cycles of lutetium dotaga FAPI-2, and following that, there was significant reduction in FAPI uptake and regression in the size of the lesion. MRI also showed decrease in perilesional edema, and there was subjective improvement in symptoms and performance status of the patient. Now coming on to tumors with high FDG uptake. First is lung. FDG is highly sensitive but less specific because many non-cancerous lung lesions like tuberculosis, other granulomatosis infection, inflammation, sarcoidosis, they may cause false positive FDG uptake. There are also false negatives like mucinous adenocarcinoma or neuroendocrine tumor, because higher SUV max and tumor to background ratio in metastasis, FAPI may have better diagnostic accuracy in brain, lymph node, bone, and pleural disease. Now, head and neck squamous cell carcinoma and carcinoma of unknown primary of head and neck region. Comparable diagnostic performance of FAPI for primary disease and local recurrence. However, FAPI presents higher specificity and accuracy for pre-operative nodal staging. And for nasopharyngeal cancer, T staging and N staging are better delineated on FAPI PET. For unknown primary, when FDG is negative or equivocal, FAPI has a role to play. Primary adenoid cystic carcinoma, again on tumor staging, nodal staging, and gross tumor volume calculation prior to radiotherapy, FAPI is better than FDG. For metastatic staging, FAPI and FDG are almost equivalent. Now coming on to esophagus, limitation of FDG because poor delineation between viable tumor and regional esophagitis, low to moderate sensitivity for nodal staging. FAPI has higher sensitivity for tumor, node, and metastasis staging in carcinoma esophagus. This is a case of carcinoma proximal thoracic esophagus, clinically T2N0, as you can see, hardly visualized on FDG PET, difficult to delineate, but beautifully shown on FAPI PET images. So this is a schematic diagram which shows role of FAPI versus FDG in oncological PET. FAPI has a role in almost all cancers except thyroid cancer, multiple myeloma, and lymphoma. Still, FDG is better across all these malignancies. And there are certain cancers like glioblastoma, head and neck squamous cell carcinoma, and prostate cancer, where FAPI and FDG, they fare almost equal to each other. So this is a FAP-RAD version 1.0 for FAP-targeted PET reporting, published in June 2025 in JNM. It has a 5 scoring pattern FAP-RAD1 and RAD2, they are most likely referring to benign lesion. FAP-RAD3 and 3B, they suggest malignancy, but they are not confirmatory, whereas FAP-RAD4, malignancy is highly likely, and FAP-RAD5, most likely malignancy, consistent with malignancy. So in all these scoring, intense FAP ligand uptake is defined as threefold SUV max of blood pool in FAPI in descending out. FAPI has role beyond oncology as well. So this slide summarizes non-oncological application of FAPI PET in inflammation and autoimmune disease. It has potential role in rheumatoid arthritis, vasculitis, and IgG4 related disease. It can show pulmonary fibrosis, so may play a role in idiopathic pulmonary fibrosis, sarcoidosis, or post-COVID fibrosis. In cardiovascular disease, it detects active inflammation and fibroblast activation in vascular and cardiac remodeling, so potential role in atherosclerosis, atrial fibrillation, and post-myocardial infarction remodeling. In chronic inflammatory diseases like tuberculosis, osteomyelitis, chronic prostatitis, musculoskeletal disorders like osteoarthritis, tendinopathies, post-surgical healing assessment. And for liver disease, it visualizes hepatic fibroblast activity measure in chronic liver disease, correlates very well with fibrosis stage. So it may have a potential role in non-alcoholic steatohepatitis, viral hepatitis, and biliary disease. And renal and neurological condition, it may have role in chronic pyelonephritis or transplant fibrosis. As you can see, these are the foci of chronic pyelonephritis. In post-surgical and wound healing, it may have a potential role for monitoring. This FAPI-PET is a promising tool to image fibroblast activation protein and fibrosis across a wide spectrum of non-oncological disease. So these are the non-oncological pathologies that show variable FAPI uptake, and the highest is being shown with myositis ossificans. So this slide shows the potential false positive findings on FAPI-PET done for oncological imaging. So whoever is reporting FAPI-PET should have a knowledge which all the non-malignant lesions that can show high FAPI avidity to include in the report, so that the report accuracy is fairly high. And all that glitters, they are not gold. We know it. So there are certain limitations of FAPI PET-CT as well. The number one is lack of standardization. Because the FAPI PET has not yet been standardized, there are physiological uptake and background in salivary gland, lung parenchyma, liver, spleen, kidneys, and bowel. It has lack of disease specificity. As you can see, there is a subset of condition which show FAP expression across benign condition and cancerous condition. There are false positive as well, like inflammatory infectious disease, fibrotic lesions, and limited data in certain population like elderly population or pediatric population. Quantification challenges are definitely there because lack of standardization of SUV cutoff and kinetic data, variability in FAP expression across many lesions, and it has very limited availability and access. They are not widely available across many regions. Cost and logistical considerations are there, and limited outcome data. So to interpret FAPI-PET in the right clinical context, we have to correlate with other imaging, histopathology, and clinical findings. This is a very busy slide which compares FAPI-PET head-on with FDG-PET across oncological and non-oncological indications. These are the physical properties, and these are the normal physiological activity of FAPI. As you can see, FAP and FDG. As you can see, FAPI has very mild physiological activity across salivary gland, thyroid, heart, and kidneys. So more or less, the physiological uptake is very high, so high lesion detectability. However, as we know, there are some certain strengths of FAPI-PET and as well limitation of FAPI-PET. So both FAPI-PET and FDG-PET, they are complementary to each other. At this point, we cannot say which one is better or which one is, worse. So choice of tracer should be guided by the clinical question, tumor biology, and the information required. To conclude, it can be an alternative to FDG PET, where fasting blood sugar is uncontrolled, or dextrose containing IV fluids patient is on, or the patient is on corticosteroid or insulin. Fasting status is not required. Earlier time point imaging at 10 minutes with FAPI is quite possible. FAPI PET has definite impact in hepatopancreatic biliary malignancies, GIT malignancies, triple negative breast cancer, colorectal cancer, sarcoma, ovary, because we can give FAPI theranostics as well. So it can be a part of combination therapies with immune checkpoint inhibitors, chemo and targeted therapies. And with theranostics, we are seeing meaningful responses with manageable adverse effects. So FAPI PET offers practical advantage over FDG and is emerging as a powerful tool in precision oncology. Thank you for your patient hearing, and I'm obliged. Thank you so much.
We thank Dr. Das for his excellent presentation. Of course, FAPI is a very promising agent in the near future, not only for oncology, but for other applications, as already said. And now I'm very pleased to welcome on the floor Dr. Yanis Karfis, one of the prominent doctors of Greek diaspora, who works in Belgium, in Brussels, and he chairs the Center of Excellence of ENETS, the Belgian one. And his talk is very interesting because we have two branches to select the Theragnosis projects. One is the substance that we choose to penetrate cancer, and the second is which isotope. For both these connected elements, Yanis will give us an interesting talk, I presume.
So thank you, Professor Darcheris, for the invitation. Of course, Ioannis Koutsikos also. And thank you, GE, for this high-value seminars. My presentation, I will speak about alpha emitters and all the challenges that we are facing and we will facing on the way to implementation in our clinical practice of tomorrow. I have nothing to disclose related to that topic. Probably I will skip this slide for the sake of time. Alpha emitters have specific physical properties. They have high particle energy, high linear energy transfer, meaning high energy compared to the length of the particle. They have high mass, short penetration range, and they produce high cluster linear tracks. And these are very effective, effective in killing cancer cells, mainly via the creation of double-strand DNA breaks and reactive oxygen species, while in parallel, we have minimal toxicities in normal surrounding tissues. It is estimated that a single alpha emission can produce DNA breaks as 100 to 1,000 of beta. And this cytotoxic effect can be obtained via transversal tract within the nucleus. And that's why it is believed that alphas are more effective for micrometastasis, although this it's not proved at least yet. If we are considering the radiobiological effects of alpha emitters, we have direct effects, dense ionization with around the primary particle track, as I said previously on the previous slide, generating high reactive oxygen species and nitrogen radicals, inducing double-stranded DNA breaks, and extensive damage to other cellular components like mitochondria. This whole sequence of events induce apoptosis, chromosomal aberration and instability, and eventually tumor cell death. We have also non-targeted effects at short and long distance, like bystander effects or the activation of systemic immune-mediated effect, like dumps. Dumps are actually danger signals that alert and activate the immune system. This is a table, a busy table with the most clinically meaningful alpha emitters. I will speak about actinium 225, lead 212, and astatine. Terbium is a relative new. We don't have so much data in our disposal. Actinium, it is produced by a generator who have limited, of course, not this isotope, we have limited availability, limited capacity of SPECT imaging, but most of the data that we have in our disposal currently come from actinium, related mainly to prostate and neuroendocrine tumors. Lead, it's also a rising agent, also produced by generator. With lead, the imaging is much more easier compared to actinium. One of the advantages that we have, the production is scalable, and there are currently phase 1 and 2 studies that are ongoing. Astatine is the most, I will say, the most clean option because it is the only isotope that allows proper dosimetry. This is a list of the current actinium trials, and I will mainly targeting mainly PSMA and somatostatin receptor. I will focus on two of them, the PSMA trial with a PSMA Trillium, sponsored by Bayer, and the actinium trial sponsored by Race Bio. The PANTHA trial is addressed to patients with progressive metastatic hormone-resistant prostate cancer that have been previously treated with at least one line of novel anti-androgen therapy and a positive PSMA PET. Positive PSMA PET was defined as a PET with at least one PSMA positive lesion assessed by central review. Patients are randomized. Actually, it's a phase 1 trial. Patients are divided into 3 groups. The first group is patients that were never received chemotherapy. They are chemo naive. The second group is patients that receive at least 1 or 2 lines of chemotherapy, but not lutetium PSMA. And the third group, the dose expansion, is patients that have been previously treated with lutetium PSMA. And patients receive 4 cycles of actinium PSMA every 6 weeks. This is the results that are announced earlier this year in ASCO GU. You can see that we have the main adverse events are xerostomia, fatigue, nausea, anemia, lymphopenia, and dyschezia. Most of them are grade 1 or grade 2, so easily manageable. We have, however, some patients that develop grade 3 or 4 toxicities, mainly myelotoxicities, but we don't have any dose-limited toxicity. In addition, this is the efficacy results. We have 40% of patients that received the lowest dose demonstrated PSMA 90 response, 62 PSMA 50 response, but this percentage was increased in patients that received higher doses, higher activities. The disease control rate was around 70 to 80%. Additionally, this good response was even more pronounced if the initial PSMA PET was showed high uptake in lesions. One other trial is the actinium-dotatate, sponsored by Race Bio. This trial is addressed to patients with GEP-NET, gastroenteropancreatic neuroendocrine tumors that have been previously treated with 2 or 4 cycles of lutetium dotatate. Again, phase 1 study with dose escalation, 3 groups of patients. And these are the efficacy results. We can see that we have few adverse events, mainly anemia, lymphopenia, also impaired renal function. Again, manageable. In terms of response, we have 7 out of 17 patients that had complete or partial response. The rest had stable disease. Only 3 patients eventually progressed under treatment. And this study was based on a previous study by our Indian colleagues that was published in 2020 in the European Journal of Nuclear Medicine. And in this publication, you can see some magnificent response like this one. A female patient with rectal NET, progressive after 4 cycles of traditional PRT, received 2 cycles of actinium-dotatate and demonstrate complete or near complete response on imaging. These results are actually triggered the phase 3 study, which is the Action 1 study. This study is addressed same indication, patient with GEP-NET, progressive after 2 or 4 cycles of lutetium BSMA. Patients were randomized between actinium-dotatate and standard of care versus everolimus, sunitinib or high-dose somatostatin analogs. Of course, we don't have any results yet, but this is the only phase 3 current phase 2 trial evaluating an alpha emitter. I will continue with lead. This is the list of current lead trial. Of course, there are much more smaller in number, and I will focus on 2 of them. The Alpha Medics trial, which is a trial addressed to patients with, again, either naive or previously treated with PRRT, receiving lead dotamtate 4 cycles every 8 weeks. And we have some preliminary results. These results were announced on the last ESMO last year in Berlin. In terms of toxicity, we have a 36-month PSF rate of 63%, which is very effective as a therapy. But on the in terms of adverse events, nearly half of the patients developed dysphagia, and that was really a new, unexpected adverse event. Many of these patients necessitate treatment with Botox or even myotomia in order to treat this adverse event. And another significant number of patients demonstrated impaired renal function with that agent. Another agent that is currently under investigation with lead targeting somatostatin receptors, the VMT. The VMT is a pegylated form of somatostatin analog that have the capacity to have a more binding in a tumor, but even more rapidly elimination via kidneys. And this study is, of course, phase 1 study, and they present initial results on the last ASCO GI last year in 2025, but there were no dysphagia or renal impairment, only alopecia, asthenia, or some kind of mild lymphopenia. There is also a third radioisotope, which is astatine. I will focus on one study that was published last year on GNM. 11 patients with metastatic iodine, radioactive iodine refractory patients with DTC, differentiated thyroid cancer, that previously had surgery, total thyroidectomy, and received at least 3 courses of radioactive iodine. This is a phase 1 study. That was the design of the study. They were treated with natrium astatine under stimulation by thyrogen and low iodine diet. And these are the results. In general, we didn't have any significant toxicity apart the usual toxicities that we have with iodine cancer, Sharia valley gland swelling, nausea, xerostomia, vomiting. Hematological toxicity was generally transient and mild and reversible. There was significant anti-tumor activity. We have more than 50% of patients, despite this advanced stage of the disease, demonstrated reduction of thyroglobulin of more than 50%. And most of the patients had on CT or SPECT imaging stable disease. This is the race of alpha emitters, just in order to illustrate what I've been discussing on my previous slides. Actinium, I will say, of course, I didn't speak about radium, but actinium is leading the way, followed by lead and astatine. What are the main challenges that we have? First and most important is the famous recoil effect. Actually, is the recoil effect is a kick that the radionuclide receives when an alpha particle is emitted. This is a high energetic process, and the recoiled energy derived from an alpha decay exceeds the energy sufficient to create the chemical bond. So that leads to a radiolysis. A radiolysis means rupture between the alpha emitter and the rest of the molecule, release of radioactive daughters, which can diffuse because they are non-labeled, and they can diffuse, they can deliver radiation to off targets. In order to illustrate that, and this is specifically even more specific for actinium, that was a slide that was presented on AINM Congress in 2023. You can see that this is a post-therapeutic imaging center for francium and bismuthium, these two daughters of actinium. And we can see that there is an uptake on the renal cortex, which is potentially responsible for the nephrotoxicity, for a nephrotoxicity. One other challenge is the dosimetry, because as I said, alphas have short particle range, and so macrodosimetry becomes inaccurate, especially if you have to calculate the dose to large organs. With the recoil, the daughters may escape the chelator and redistribute to kidneys or to other organs that are non-target, and so the actual absorbed dose may differ substantially from those predicted by the dosimetry. And for all these issues, there is a special publication, a recommendation by the EINM addressing these challenges with dosimetry in alpha emitters. And finally, the last challenge is, of course, the production, the supply, and the availability. This is you can see on the map a list of production sites, but clearly this is an editorial on a recent GNM article. The production is not sufficient to cover the demand. It is estimated that, for instance, for actinium, the current actinium production is 55 to 65 gigabytes per year. And what is needed, and only for research purposes, is 200 to 400 gigabytes per year. So clearly there is an imbalance between the supply and the demand. For that reason, several companies, mainly companies of private sector, created joint ventures in order to create structures to implement, to produce, and to make more available this kind of isotopes, like Pantera, or like the TerraPower that Bill Gates created in 2023. And I think that that was my last slides. Alpha isotopes are powerful agents in cancer therapy. This is a new class in radioligand therapy. We don't have to consider them as an increased version of the current beta emitters. This is a completely new class of drugs with new adverse events. Of course, a lot of information comes from actinium, but other trials are on the way, especially with lead. We have several challenges like a recall, the dosimetry, and the supply on this long way to implement on our clinical practice. Thank you.
Thank you, Giannis, for your comprehensive presentation. I hope that in the near future we will be also here in Greece able to use alpha emitters. Just to mention that in the recent SNMMI annual conference, the article for a statin from Watabe et al. Was granted as the best article of JNM at 2025. That means that there is focus there. Just to ask you regarding your expertise and your feeling, which of these emitters, of these alpha emitters, do you believe that in the near future will be the new lutetium?
It's too early to say because actinium is already on running phase 3 trials, so he has an advantage. But I think that we don't know who of this isotope will win the race. What is important is that with alphas, we must demonstrate a significant benefit in terms of efficacy and lesser toxicity compared to beta. If we don't have this, then I think that the whole alpha emitting isotopes will not be able to evolve into clinical practice. Okay, probably the astatine is the most cleaner one because it allows dosimetry, which is very important. Okay.
And what about the cost? The difference between alpha emitters and beta emitters?
The cost for the moment, to give you an idea of the cost, the cost is various among the centers that are doing alpha therapy. For instance, in Germany, you can treat patients with actinium PSMA, and the cost, which is not covered, of course, by any social fund, the cost can vary from 7 to 20,000 euros per cycle. Okay, and I'm not speaking about clinical trial, I'm speaking about a routine.
It's approximately the same level as beta emitters.
Apparently, yes.
Okay. My next question is, okay, are phase 3 studies about local advanced cancers and alpha emitters? I mean that, okay, in prostate cancer, the short linear range is beneficial to the patient and for side effects and it's for symmetry. What about advanced diseases?
What about other diseases? You mean other than prostate and
Other than prostate?
Yes, of course, there is in neuroendocrine tumors. Most of the studies that I show were phase 1 trials, okay, mainly focusing on PSMA and somatostatin receptors. But there are other agents, especially with actinium, addressing patients with pancreas, colorectal, and triple negative breast cancer, which I think that will be by far more interesting.
Okay, thank you. Any other question from the audience? What about from live streaming? No. No. Thank you, yes.
And now we can continue with nuclear neurology. So please, Dr. Natsios. You can come to the stage.
Okay, so let's continue with the next session with Dr. Lukas Labrakos. Dr. Lukas Labrakos is a nuclear medicine physician and the head of nuclear medicine at Iatropoulos Medical Center in Athens, Greece. So his speech is about semi-quantification nuclear neurology. So Lukas, the stage is yours. Thank you.
Thank you, Dr. Natsios. Good evening from me too. I'd like also to thank the organized committee for this nice invitation to speak about this very interesting topic regarding semi-quantification in nuclear neurology. So we must see semi-quantification as the practical bridge between visual nuclear neurology and reproducible image delivered biomarkers. It does not replace the visual read. It makes the visual impression more explicit, measurable, and easier to compare across readers. So we need to answer three questions. What exactly are we measuring? How was the number produced? And how should the number change clinical confidence? Every value we get is pipeline dependent. Acquisition, reconstruction, ROI or VOI method, reference region, normal database, and reporting threshold all influence the final result. So in nuclear neurology, semi-quantification is valuable because the disease pattern is often regional and network-based, but the interpretation must remain anchored to image quality and clinical context. I have nothing to disclose. So which are the learning objectives? First, we should be able to define the main semi-quantitative metrics used in brain SPECT and PET. SBR for dopamine transporter imaging, SUVR for PET tracers, asymmetry index for lateralized disease, Z-score for comparison with normal database, and of course, centiloid for standardized amyloid PET reporting. Second, we should understand the full processing chain. A number is not generated direct from the patient. It is generated from reconstructed images after choices about correction, smoothing, spatial normalization, ROI placement, and reference normalizations. And of course, third, we should recognize common failure points, motion, poor registration, inappropriate reference region, atrophy, partial volume effect, scanner changes, and mismatched normal database can all create misleading numerical result. So good semi-quantification is not only a software output, it is a standardized biology plus standardized physics plus standardized statistics. So what semi-quantification means? If we want to perform an absolute quantification, we would require kinetic modeling, dynamic acquisition, arterial or image-delivered input function, and tracer-specific modeling. On the other hand, semi-quantification usually use static images and normalized ratio, make it more feasible for routine clinical practice. The target region is expected to show disease-related change, while the reference region should be relatively spared and technical stable. The metric is then interpreted against a threshold or a local normal range or a validated database. Semi-quantitative does not mean approximate or unscientific. It means that the method is simplified and standardized. Its reliability depends on consistent methodology, not on the software label alone. Like, for example, for that spec, a striata binding ratio compares striata counts with background counts. In FTG-PET, regional uptake may be normalized to global mean, or pons, or cerebellum, or another reference region. In amyloid PET, cortical SUVR can be converted in centiloid if the tracer and pipeline are validated. So let's walk through its metric. SBR is typically used in presynaptic dopaminergic SPECT to estimate specific striatal binding above background. SUVR is widely used in PET as target uptake divided by reference uptake. Asymmetry index captures right to left imbalance, and it's very useful when disease begins laterally, like in Parkinson's disease. Z-score maps compare the patient with a normal database and express how many standard deviation the patient differs from expected values. This is very powerful, but only if the database matches the scan, reconstruction, tracer, age range, and analysis method. Centiloid is a standardized amyloid PET scale designed to improve comparability across tracers and processing pipelines. It is especially useful, but clinical interpretation still requires validated cutoffs and visual correlation. The ratios we get are sensitive to both numerator and denominator. A low target can be a real disease, but an abnormal or noisy reference region can also change the ratio. So always ask yourself, is the denominator trustworthy? So this is the pipeline in every exam. Each number comes from a sequence of decisions: how the patient was prepared, how the tracer was injected, when the scan was acquired, how motion was controlled, how images was reconstructed, and of course, how ROIs were placed. Reproducibility is achieved by logging this workflow. If one site changes reconstruction, parameters, smoothing, attenuation correction, or analysis software, the same patient may receive different numeric values without true biological change. For serial imaging, the comparison is only meaningful when the pipeline is comparable. Ideally, repeat scans should perform in the same center. Okay, let's start with the acquisition quality. Patient motion is one of the most important source of errors in brain SPECT and PECT because small structures, especially the striatum, can be blurred. Blurring can lower apparent uptake and reduce contrast, producing this way a false impression of disease severity. Iterations, subset, post-filtering, attenuation correction, scatter correction, resolution recovery, smoothing, all alter contrast and noise. A more aggressive reconstruction may increase apparent contrast, but also increase noise. A smoother reconstruction may reduce noise, but blur small structures. Like in that spec, striatal SBR is particularly sensitive to spatial resolution, slice orientation, head positioning, and ROI definition. For FTG PET and amyloid or tau PET, cortical thickness, smoothing, and partial volume effect influence regional uptake. Validate, it's the best, validate the full local pipeline using Phantom if possible. otherwise with normal controls or vendor-validated reference ranges. Do not import thresholds from another software or protocol without validation. Now, if we produce manual ROIs, of course, we need expert adjustment, but they give precise results, especially when combined with MRI fused images, but is time consuming and may introduce interoperative variability. Small differences in placement can change values, especially in striatum or small cortical regions. Atlas or template-based voice improve reproducibility, but depend on accurate spatial normalization. Registration errors can place a template region partly outside the intended anatomy, especially in patients with atrophy, ventricular enlargement, tumors, prior strokes, or post-operative changes. MRI-based voice provide better anatomical precision and are very useful for PET, especially cortical tracers, but they add steps. MRI segmentation, PET MRI co-registration, quality control, and sometimes partial volume corrections. Voxel-wise methods such as SPM or surface projection methods are powerful for pattern recognition, but they should not be read as simple yes or no maps. They are statistical outputs and need corrections, database matching, and visual correlation. Now, the reference region is the denominator of most semi-quantitative ratios. It should be biological present in the disease under study, large enough to be statistically stable, and technically easy to segment without contamination. For that aspect, common reference approaches include occipital cortex or whole brain background, excluding, of course, striatum. The key here is to avoid including specific striata signal or extra cerebral activity. If the background region is contaminated or inconsistent, the SBR will be distorted. For FTG PET, global mean normalization can help reveal regional patterns, but it can also hide diffuse disease or exaggerate relative sparring. Pons, cerebellum, or sensory motor cortex may be used depending on the clinical question and software. For amyloid and tau PET, cerebellar gray matter, whole cerebellum, or white matter reference regions may produce different values and different longitudinal behavior. So the chosen reference must match the validated pipeline and cutoff. Never report a ratio without knowing what was used as the denominator. Okay. Now, let's start with DATSPEC. DATSPEC semi-quantification is mainly used to support visual diagnosis. The typical pattern begins in the posterior putamen after often asymmetrically and may progress to involve the anterior putamen and caudate. What SBR means counts in the striata target minus reference counts divided by reference counts. This attempts to isolate specific binding above non-specific background. Values must be calculated separately for right and left caudate and putamen. Also, useful outputs include right and left putamen SBR, caudate SBR, putamen to caudate gradient, asymmetry index, and z-scores. Those help when the visual impression is borderline in asymmetry or when comparing with a normal database. Of course, semi-quantification is crucial in balance loss cases, where we have symmetric loss of dopaminergic transporters, often seen in Parkinson plus syndromes. be cautious because a normal value does not always mean no disease. It means that at the time of imaging, there was no significant presynaptic dopaminergic deficit. An abnormal, on the other hand, an abnormal scan supports degenerative Parkinsonism, but then does not separate Parkinson from Parkinson disease from Parkinson plus syndromes. Okay. Also, severe disease may show floor effect, where values cannot meaningfully decline much further. Now, a very recent study from Japan published in 2025 tries to compare the ability of different quantitative indices in that spec for differentiating dopaminergic neurodegenerative disease. The question here was, which quantitative index best separates dopaminergic neurodegenerative disease from non-dopaminergic conditions? Distribution volume ratio, that's the DVR, and binding ratio, BR, were measured by analyzing clinical DAT-SPECT images of 29 patients with dopaminergic neurodegenerative disease, including dementia with Lewy body and Parkinson disease, and 18 patients with non-neurodegenerative disease. Additionally, they compute the specific bind ratio based on BOLD method and the maximum and mean standardized uptake values. That's SUV max and SUV min. So what they conclude is that the caudate to occipital lobe, putamen to occipital lobe, and striatum to occipital lobe ratios on DVR and putamen to occipital lobe and striatum to occipital lobe on binding ratio were the most useful DAT quantitative indices. Those indices can be compared with SPR or SUV, suggesting that comprehensive evaluation improves the diagnostic accuracy of neurodegenerative disease. Another study from Germany, published against very recently in 2025 on Annals of Nuclear Medicine, tries to provide fully automatic scanner-independent 5-level categorization of the eoflupine uptake in striatum. A total of 3,500 scans from 2 in-house and 2 external data sets were used in this study. A convolutional neural network, CNN, was trained for the categorization of the eoflupane uptake in striatum and putamen in both hemispheres according to 5 levels: normal, borderline, moderate reduction, strong reduction, and almost missing. Reference standard labels for the network training were created automatically by fitting a Gaussian mixer model to histograms of the specific eoflupine binding ratio separately for caudate and putamen and separately for its set. The CNN was trained on a mixed scanner sample and tested on one independent, identically distributed test database and one out of distribution test dataset. The accuracy, what they found, the accuracy of CNN for the 5-level prediction of the eoflupine uptake in caudate and in putamen was 80% and 78% in IID test dataset and 78 and 76 in the OOD test dataset. So they conclude that automatically scanner independent 5-level categorizations by a CNN model is feasible and clinical useful accuracy. Now, let's pass to FTG PET semi-quantification, which is pattern-based. The goal is not only to find a low number in one region, but to identify a disease-consistent metabolic network while excluding artifacts and mimics. In Alzheimer's disease, the classic pattern includes posterior cingulate, preconus, and temporal parietal hypometabolism, often with relative preservation of primary sensory motor cortex. In dementia with Lewy body, occipital hypometabolism and relative preservation of posterior cingulate metabolism compared with preconus and conus can support the diagnosis. In frontotemporal dementia, frontal, of course, and anterior temporal hypometabolism is very common. What about the Z-score maps? They highlight deviation, as we said, from a normal database, but they depend strongly on age matching, scanner harmonization, and normalization method. A colorful map is not automatically a diagnosis. The pattern must match the clinical presentation and the raw images. Hyperglycemia, recent seizure, head motion, infarcts, tumors, and severe atrophy can alter apparent metabolism and semi-quantitative maps. A study again from South Korea published in 2025 in Journal of Nuclear Medicine tries to improve FTG PET quantification through a spatial normalization method. If we want to make an accurate quantification for FTG PET, we require matched three-dimensional TAF1 MRI scans of the same individual to provide detailed information of brain anatomy. So what they propose to transfer learning approach to adapt a pre-trained deep neural network model from amyloid PET to spatially normalize FTG PET images without the need of three-dimensional MRI. The method is based on a deep learning model for automatic spatial normalization of FTG brain PET, which was developed by fine-tuning a pre-trained model for amyloid PET using only 103 FTG PET and MRI scans. After training, the algorithm was tested on 65 internal and 78 external test sets. All TAF1 MRI images with 1 millimeter isotropic voxel size were processed with free surface software to provide cortical segmentation maps used to extract a ground truth regional SUV ratio using cerebellar gray matter as a reference region. Those values were compared with those from spatial normalization-based quantification method using the proposed method and statistical parametric mapping software. The results, the method shows superior spatial normalization compared with statistical parametric mapping. This highlights the efficacy of transfer learning, which requires a small number of data set than does the original network training, though increasing the potential of broader use of deep learning-based brain PET spatial normalization techniques for various clinical or research radio tracers. Now, let's pass to amyloid and tau PET. Here we can use also semi-quantification to improve consistency, especially in research and borderline cases. For amyloid PET, cortical SUVR summarized tracer retention across predefined cortical regions. Very important, validated pipelines may transfer SUVR to centiloid values to improve comparability. Centiloid values start from 0, which is anchored near young control like amyloid signal, and to 100, near a typical mild Alzheimer's disease amyloid level. Of course, this does not mean that every clinical cutoff is exactly the same for every tracer or every software package. Thresholds must be validated. Tau PET is more regionally specific and stage depending. ROI selection may target medial temporal, inferior temporal, temporoparietal, or BRAC-like composite regions, depending on the question. Off-target bindings and age-related signal can complicate interpretation. Always reporting tracer, acquisition window, software, target composite reference region, whether partial volume effect correction was used, and of course the cutoff or database applied. Visual positivity and quantitative positivity should be recognized when they disagree. Again, a study about tau PET was done in very recent this year, at the early of this year from USA, published, which tries to stage Alzheimer's disease through amyloid and tau PET. They evaluate Alzheimer's disease biological staging by identifying meaningful tau PET cut points to define the four biological stages in a well-characterized cohort and to describe the features of individuals placed into different biological stages. The primary analysis included 896 participants in the Mayo Clinic study. A validation cohort consisted of 328 participants in the Alzheimer's disease neuroimaging study. Both cognitive normal and impaired individuals with positive amyloid PET and tau imaging were included. Tau PET cut points were identified with Gaussian mixture models to characterize Alzheimer's disease biological states in study participants with different clinical diagnosis and objective degrees of cognitive impairment as measured by mini mental state examination. A tau PET cut point in the medial temporal region and two cut points in the temporal parietal region were identified to produce collectively the four Alzheimer's disease biological states described in the criteria. The results: increasing stage was associated with great likelihood of mild cognitive impairment and dementia, and worsening cognitive performance on mini mental state examination, results that was reproduced in the independent Alzheimer's disease neuroimaging initiative cohort. Now, we can also perform semi-quantification in brain perfusion Speg using regional perfusion ratio, asymmetry index, or z-scores. Again, apply the same principles: reference region, database, motion control, and pattern recognition matters. And also in brain tumors or receptor imaging. Semi-quantification tumor to background ratio or SUV-based metrics may be used for lesion characterization, therapy planning, or follow-up. In interpretation, we must consider inflammation, necrosis, prior treatment, or lesion size. Inflammation and TSPO PET can also be quantitative measure, but it's biological. It has biological variability with genotype effects for some tracers, non-specific binding, and reference region uncertainty make the interpretation challenging. Don't forget the same logic as we said: validate the method, inspect the image, and report the uncertainty. I'm almost finished. Now, what are the main pitfalls of semi-quantification? As we said, motion blurs uptake and reduce apparent contrast. Registration failure places voice in the wrong anatomy. Atrophy and partial volume effect dilute cortical signal. Wrong reference region can distort aberration. Database mismatch can make a normal study look abnormal. Okay, in that aspect, head tilt or poor registration can change the apparent shape of the striatum and affect coded to putamen separation. In FTG PET, global normalization is in very diffuse hypometabolism can make relative sparse regions look falsy hypermetabolism. In amyloid PET, white matter split in and cortical atrophy can influence, of course, SUVR. Quantification should be accepted only after the following are checked: raw projection, sinogram, reconstruction imaging, ROI overlay, normalized region, color scale, and clinical history. And now I'm almost finished. The strong report, okay, should be transparent enough that any other physician can understand how the values was produced. Okay, include tracer, acquisition time, scanner time, reconstruction method. The results should provide both visual pattern and numeric values. The interpretation should say whether the quantitative results is concordant with the visual impression. And don't forget, semi-quantitative results support the visual interpretation. Okay. Now let's summarize all. Semi-quantification improves reproducibility, but only when the pipeline is standardized and quality controlled. Three important pillars, don't forget: image, number, context. The image tell the pattern equality. The number adds reproducibility and comparison, and the clinical context determines whether the pattern is meaningful for the patient. Take-home point: ratios are not absolute truth. Reference region matters, ROI placement matters, normal database must match the method. The best nuclear neurology interpretation is not visual versus quantification. It's visual plus validated metric plus clinical reasoning. Thank you very much for your attention.
Thank you, Lucas, for this excellent presentation. And I think we have the audience. If there is someone to ask a question, it's open for discussion. Okay, let's have my question. So,
Okay.
what about the synergistic role of AI and quantification?
Yeah.
What is your approach? So, and the role of nuclear medicine physician?
Yes, there are. It's very promising, that's for sure. Especially when we use maps from MRI Atlas. There are some few studies that using artificial intelligence as besides those I show with CNN neural network. There are also some others that what they do, they use those maps from MRI to determine the areas of interesting. So maybe in the future we will have more validation is the issue here. As we saw, all those studies are not having the sufficient number of cases and patients study. So we're not knowing for sure that those paths are correct now. More studies must be performed with a lot of data sets. For every software using AI to be validated for clinical practice.
Well done, Lucas.
Thank you.
I have some questions and um, currently to set some issues of the daily practice into discussion. According to my experience, either using Z-scores or celluloid and your eyes, for the time being, especially celluloid, wins our eyes, to be honest.
It's true.
To be honest. Because if, and you are right, emphasizes on that, the denominator is the right, and all the steps are doing well, from choosing the dose, the timing, the reconstruction, and everything else, then the engineers that created these applications are very good enough, and the physicians to choose the denominator and present the final result. Either it is FTG or
amyloid or tau,
or it is tau, or it is the amyloid plug radiopharmaceuticals. This is the beginning, because artificial intelligence overcomes the need of an application, and the engineering, the software doing of examinations.
I think
That means that feeding artificial intelligence with our data, the data of examination, the data from a patient, then artificial intelligence will choose the denominator,
exactly.
the procedure, the database, and so on, and will present. I'm afraid that in the near future, the machines will beat us for the good.
You're very right, because I think we're kind of unlucky regarding beta amyloid or tau imaging, because now we have the artificial intelligence already in our doors knocking, but we don't have enough experience, our eyes, they don't have enough experience with tau or beta amyloid scans. So we find ourselves next to the artificial intelligence, try to compete to train our eyes while the artificial intelligence is trained faster than us. In the other hand, like in that scan, I think we have our eyes has a very experience seeing the pathologic or normal image. So there you see that a lot of software coming to determine the ROIs or what is normal or abnormal. But if you have a trained eye, you can find the result easy in your mind, and then you just see it again with your software. That's, I think, the unlucky case with beta amyloid and tau scans.
The pathology on the dopaminergic pathways are more sufficient and clear than in amyloid plaque and tau plaque accumulations. The only difference is to discriminate if it is Parkinson plus disease or Parkinson disease, the differences in picture. And of course, we have many nuclear medicine physicians trained reporting that scan. But I insist that our role is to assist the artificial intelligence and the applications
To guide it.
and not
Yeah.
to guide and not the artificial intelligence help us. And I think that we do something. No, we don't report one physician. We only report two and have at least two and have a consensus on reporting.
That would be the ideal.
The best way is first to have the visual estimation of the study,
Correct.
and then
That's
apply.
in every, I think,
the-
exam in neurology. First see the image and second see the numeric values.
It's a very interesting and promising field. Thank you again.
Thank you.
Okay, so let's move at the next presentation with Professor Vanna Varlotasiou from University of Larissa. I think we are, I cannot see. Okay, good afternoon, Professor Varlotasiou. So the title of the presentation is When Plaques Speak, Amyloid PET gives them a voice. So let's hear Professor Varlotasiou.
Good, dear presidents, dear colleagues, good afternoon. I can't hear you well. I don't know what is the reason for that. I don't know if you see my presentation in full screen. Is it okay?
It's not in full screen, so you have to click at the bottom.
I can see it on full screen in full screen on my laptop, but okay, I'll try once more. Now?
Yes, success.
Okay. I'm really very sorry I could not come to Athens and see you and watch this event live. Maybe the next time. Well, I wanted to declare that the title of this lecture was Dr. Kutsko's idea to speak about amyloid PET, which gives voice to plaques when they speak. Okay, I want to start with a short introduction to neurodegenerative dementias, and to say that dementia is an umbrella term, and it is used to describe various brain diseases and their symptoms, which may include memory loss or impaired judgment or personality changes, and in general, the inability of a person to perform daily activities. And the most common cause of neurodegenerative dementia is Alzheimer's disease, of course, and other causes are frontotemporal dementia or Lewy body dementia and vascular dementia as a cause of dementia in general. The characteristic hallmark of degenerative dementias is the accumulation of abnormal proteins either in the extracellular space, such as beta-amyloid in Alzheimer's disease, or in the intracellular space, such as tau protein or TDP43 or alpha-synuclein in other types of dementias. The accumulation of abnormal proteins results in various pathological processes and finally in neuronal cell death. And according to the amyloid cascade hypothesis in Alzheimer's disease, the accumulation of beta-amyloid results in the formation of amyloid plaques. And this process is followed by the accumulation of tau protein and the formation of neurofibrillary tangles, and finally neuronal injury and synaptic dysfunction and neuronal loss. This is a figure that it is used very often in presentations, and this represents the pathological processes during the progression of the diseases from the preclinical stages until the clinical presentation according to the ATN system classification system. Amyloid beta deposition begins very early in the progress of the disease, and before even 10 or even 20 years before the clinical presentation. Finally, the nucleus and the cell itself disintegrate, and only a tangle of fibrils indicates the place where a neuron was previously located. This is what Alzheimer said in 1907, the first doctor who described the disease in the first patient. Alzheimer's disease is a clinical syndrome, and the most common type is the amnestic syndrome, which accounts for about 25% of patients. And less common phenotypes are the low-grade variant of progressive primary aphasia and the posterior cortical atrophy. And more atypical serotypes such as cortical basal syndrome, the frontal variant of Alzheimer's disease, the non-field primary progressive aphasia, and the semantic variant, and finally the non-amnestic ID with TDP43 pathology. At this point, I wanted to show you, I thought it was interesting to show you the history of Alzheimer's disease, which was released by Nature journal about 2 years ago, and to show some of the most important dates and discoveries during the history of the disease. As we said in 1906 and 7, the first patient, which was examined by Alzheimer, and the very next year, after a lot of years, the identification of meta-amyloid plaques in brain in 1984, and it was followed at different time points with the findings of various genes which are implicated in the pathology and the appearance of the disease. And in 1991, the Bragg staging system, which is used for the staging of accumulation of beta amyloid in the brain, and the more genes and the production of the first vaccine in 1999, the role of inflammation in the pathogenesis of Alzheimer's disease. In 2004, the first amyloid PET tracer, Pittsburgh compound, PIP, and the more genetic risk factors in 2013. In 2020, lab-based biomarkers for Alzheimer's disease, and 2021, the first anti-amyloid antibody, aducanumab, which was approved by FDA. So, which is in the current clinical setting, which is the role of amyloid PET for Alzheimer's disease. The main role is the establishment of AD diagnosis, the early diagnosis and the differential diagnosis of the disease, especially in the new era of the anti-amyloid treatments, which are becoming available widely. The information we have from amyloid PET imaging may provide guidance to the clinical care team to optimize care planning of each patient. Again, the same figure, and I want to say that amyloid PET corresponds to the A component of the ATM classification system. Amyloid PET enables the detection of beta amyloid in vivo many years before the appearance of the clinical symptoms. And this modality has been validated against histopathological standards, and the studies have indeed confirmed its correlation with the neuropathological staging systems. These images are from the first patient where PIB amyloid PET was performed. Due to the drawback of the short half-life of carbon-11, new fluorinated tracers have been developed. These tracers show non-specific binding in white matter higher compared with PAP, as we see in this image. And moreover, its fluorinated tracer it shows distinct pharmacokinetics, image contrast properties, and degrees of non-specific white matter binding. As we see in this table, there are differences in the injected dose, the acquisition start time, the scan duration. So all these factors necessitate careful selection based on institutional expertise and logistical factors. We also must have in mind that maybe there are slight differences in the accumulation of these tracers in the brain cortex, in the binding in the amyloid plaques. Increased amyloid tracer uptake is seen in over 90% of patients with Alzheimer's disease. It has been reported that increased tracer uptake is first in the early stages of the disease, is seen in the orbitofrontal cortex and the cingulate and the precuneus, and in inferior temporal cortex, and this accumulation expands to other brain regions involving more extended areas in frontal lobe, in parietal lobe, and of course, finally in the striatum. Beta amyloid PET provides a better staging and follow-up of extent and location of beta amyloid in vivo. It is a non-invasive technique that has a very high sensitivity. And it is indicated when lumbar puncture is contraindicated, or the patient refuses to undergo this procedure, or when the CSF results are inconclusive. However, it has also been found early in the course of beta amyloid imaging that amyloid PET may be positive even in healthy subjects, and it is getting more and more positive with the advance of the age of the subjects. And it has been reported to see positive amyloid PET in 65% in normal subjects who are older than 80 years. This means that amyloid PET has very high sensitivity and negative predictive value. If PET amyloid is negative, Alzheimer's disease is excluded, but has low specificity and For these reasons, amyloid PET imaging alone should not serve as a surrogate for a clinical diagnosis of Alzheimer's disease. Alzheimer's disease, as I said previously, is a syndrome with various subtypes. These subtypes have identical pathology but different phenotype. The studies have shown that the distribution of beta amyloid PET uptake in these AD subtypes is almost the same, have almost the same pattern between these types. So amyloid PET cannot distinguish specific Alzheimer's disease syndromes. For this purpose, it has been proposed that the use of tau PET and FTG PET may be very important in the differential diagnosis because tau PET and FTG PET patterns are different between the clinical phenotypes of Alzheimer's disease. And here we see some examples of FTG PET in typical Alzheimer's disease, posterior cortical atrophy, Alzheimer's disease, and the logoped variant. However, let's think that amyloid deposition starts, as we said, 1 to 2 decades before the clinical presentation. And at the time of clinical presentation, amyloid deposition has reached a plateau. So when we perform amyloid PET, we perform amyloid PET at the time of clinical presentation of the, at least of the first symptoms of Alzheimer's disease. At this time, amyloid deposition has already reached a plateau. So if we had the possibility to perform amyloid PET at earlier stages, maybe we could see different patterns of amyloid PET between the clinical phenotypes of Alzheimer's disease. And I found this publication important that I wanted to show it to you. If we see in various subtypes of AD, frontal, parietal, or occipital subtype, at the early stages, we see that the pattern of amyloid tracer PET uptake is the same. If we perform in early stages, you see that there is great, absolutely different tracer uptake pattern. Frontal subtype is associated with classic AD profile. Parietal subtype is associated more often with early onset Alzheimer's disease, while occipital subtype is associated with faster cognitive decline and vascular pathology. Beta amyloid PET is very useful for the differential diagnosis of Alzheimer's disease from frontotemporal dementia, but not for the differential diagnosis from Parkinsonian syndromes, Lewy body dementia, or Parkinson's disease dementia. In these cases, that scan is a very useful tool for the differential diagnosis, since in Alzheimer's disease, the results are negative. Subjects with MCI, mild cognitive impairment, very important, the amyloid PET imaging. It has been found that in MCI subjects, and especially those with the non-amnestic type of MCI, amyloid PET tracer uptake, increased amyloid PET tracer uptake, is a prognostic factor that these patients will progress to Alzheimer's disease. It has been found that 67% of these subjects with high tracer amyloid tracer uptake will progress to Alzheimer's disease, compared with 5% of those who show low, very low tracer uptake. And in these images, we see different cases, normal healthy subject with negative amyloid PET, just non-specific binding in white matter, a healthy subject with low amyloid tracer PET uptake, MCI negative PET, amyloid PET, and 2 cases of MCI positive amyloid PET, where the pattern of amyloid tracer uptake is similar to that seen in Alzheimer's disease patients. In this trial, which included 1,060 100 patients, MCI patients or cognitively healthy subjects, it was found that in MCI patients who had amyloid positive PET, 40% of them progressed to dementia the next 5 years. And with a sensitivity over 90% and specificity ranging from 56% to 80%. And in cognitively healthy subjects, those who had amyloid positive PET, 20% of them progressed to MCI in the next 5 years. And another important result finding in this trial, it was that about 30% of healthy subjects who were over 60 years old were amyloid positive. Finally, which is the clinical impact of amyloid PET in the diagnosis and differential diagnosis of dementia, and this was studied in the Imaging Dementia Evidence for Amyloid Scanning Study, which showed that included a large number of patients with MCI or dementia of uncertain cause, 11,000, over 11,000 participants. This study shows that the etiological diagnosis changed from Alzheimer's disease to non-Alzheimer's disease in 25% of patients, and the opposite from non-Alzheimer's disease to Alzheimer's disease in 10.5% of patients. And there was a change in patient management in 60% of patients with MCI and over 60% in patients with dementia. So we see how important is amyloid PET in the diagnosis and the management of patients. About 2 years ago, the Alzheimer's Association and Society for Nuclear Medicine and Molecular Imaging Work Group proposed several clinical scenarios for the use of amyloid and tau PET, and these scenarios include cases with MCI or dementia, either they are younger than 65 years old and in whom AD pathology is suspected, or they are older than 65 years old and the dementia syndrome is consistent with the AD pathology. Also patients with MCI or dementia who have atypical features, or patients who have equivocal or inconclusive results on CSF biomarkers, or in MCI patients for prognostic reasons, to receive prognostic information regarding the progression, the possibility of progression to Alzheimer's disease. Amyloid PET interpretation is either visual or quantitative using SUV ratios or centiloids. A visual interpretation is made using, let's say in the next slide, using grayscale or inverse grayscale or color scales. Each tracer suggests the corresponding color scale. And we focus on specific areas in the brain cortex, and these areas are the medial orbitofrontal, posterior cingulate gyrus and precuneus, the striatum, and the lateral temporal and parietal cortices. Striatal uptake is suggested to interpret the uptake in this region, and striatal uptake follows the cortical uptake in sporadic Alzheimer's disease. In general, there is a high inter-rater agreement, despite applying different visual rating protocols for all fluorinated amyloid tracers. However, there may be several interpretation pitfalls with visual reading, and it can be difficult to interpret amyloid PET images with a low signal-to-noise ratio, diffuse off-target binding, motion blurring, or attenuation correction artifacts which can mimic positivity, or in cases of cortical atrophy. So it is suggested to use centiloids. Centiloids method has gained a large field, and its use has been increased the last years. And in this, the range of the values are between 0, which corresponds to PAB uptake and controls, and 100, which corresponds to PAB uptake in advanced typical Alzheimer's disease patients. In this table, we see the centiloid deviations for converting SUV ratios to centiloids, so we can use any tracer we want or is available in our department, and then we can compare using the centiloid scale. We can compare our results with the results of other centers of other studies who have used different tracer. According to the centiloid scale, values below 10 exclude Alzheimer's disease pathology, while values over 35 to 40 centiloids reliably detect and established Alzheimer's disease pathology. Values between 10 to 30 represent the gray zone. Values from 10 to almost 20 represent prediction of Alzheimer's of amyloid accumulation, while values for between 20 to 30 represent amyloid positivity onset. It has been found that there is a high agreement between visual read and quantification in advanced clinical cases. It is the easy scenario. And in these studies, it was found that there was agreement over 90% using either SUV ratios or centiloids. But what happens when we have cases in the gray zone? Then, at least for the less experienced readers, but even with the more experienced ones, in these cases, it may be difficult to distinguish between marginal and substantial burdens of amyloid, of beta amyloid. So in these cases, we really need centiloids. Again, may be difficult, and in these cases, we should ask for a second opinion, for an additional opinion, and we should review it, the study. And in this slide, we see the increase of published studies using centiloid in their methods. and the use of celluloids, the increase of use of celluloids in clinical trials. We have entered in the new era of anti-amyloid therapy. The first anti-amyloid antibody was approved by FDA in 2021. It was aducanumab, and it was followed by the approval of lecanemab and donanemab. The new therapeutic approaches for Alzheimer's disease demand the use of biomarkers. Biomarkers, either imaging biomarkers or CSF biomarkers or blood biomarkers. That is very useful because it can serve as an imaging biomarker for beta amyloid as well as for tau accumulation, for tau burden, and it is very useful for the early diagnosis of Alzheimer's disease based on imaging of amyloid and tau, since there is greater benefit from these treatments when they are used at the earliest stages of the disease. It is also important for the evaluation of response to treatment and the amount of the beta amyloid which is needed to remove to achieve a response to treatment, and finally for the follow-up of patients and the detection of beta amyloid reaccumulation. Nuclear molecular imaging has the possibility to provide information for amyloid burden, for tau protein, and for the neurodegeneration using FDG. These tracers are available for clinical use, but there are also other tracers which are used in the clinical setting, in the research studies, and which are not have not been available for daily clinical using, but also provide significant information for the pathogenesis of the disease, even in earlier stages, such as the imaging of neuroinflammation and synaptic density. Amyloid PET is a key for the approval of anti-amyloid therapies, and it is necessary for the approval of aducanumab, lecanemab, or donanemab. In the clinical trials where aducanumab was used, we see the results in responders. In the first line, we see a patient who received placebo, and we don't see any difference in amyloid tracer uptake between the baseline and the 1 year after treatment, while in the other cases we see a reduction of amyloid burden according to the dose of aducanumab. And in the clinical trials where lecanemab was used, we see that the lecanemab group showed amyloid tracer uptake reduction compared with the placebo group, where there was no any difference between baseline and follow-up imaging. And as well as we see that the lecanemab group showed slowing of progression of cognitive impairment compared with the placebo group. Amyloid PET imaging is very important for the inclusion and therapy monitoring. And in this study, Trailblazer, which used donanemab, amyloid and tau PET was used for the inclusion of patients patients had amyloid PET positive as well as tau PET positive, low, medium, or high tau burden. Again, we see they found, and we see in these curves that the donanemab group showed a reduction of amyloid PET measured with the centiloids compared to placebo group, and as we saw with lecanemab with the previous slide, these patients also showed a slowing of cognitive impairment progression compared to placebo group. So the same group of Alzheimer's Association and the Society for Nuclear Medicine and Molecular Imaging proposed the use of amyloid and tau PET for the selection of patients where appropriate to receive these treatments and the evaluation of treatment response. I wanted to say that we must get more familiar with the terminology TRAC, the terminology treatment-related amyloid clearance. TRAC reflects that natural disease mechanisms have been altered and testifies biomarker evidence for reduction of amyloid plaques. And this terminology describes persons who had already diagnosis of Alzheimer's disease confirmed with the use of a biomarker. They have received treatment at the amyloid antibodies, and they have undergo a follow-up biomarker test, which is indicative of amyloid clearance. Currently, this biomarker is limited to PET imaging. And in this case, we see that there is no response, no drug. There is no significant change in centiloids between baseline and the follow-up study after the treatment, 94 to 92 centiloids. In this case, we see a partial drug, partial response from 92 centiloids to 32 centiloids. In this case, we see full track, full response to treatment from 64 centiloids to 20 centiloids, and which are under the PET positivity drops below the threshold positivity. And another important conclusion of the results of various studies, of course, not only from this case, is the notice that when the amyloid burden is lesser, the better the results. In Trailblazer, where lecanemab was used, has also provided some information about the cutoff of the cutoff value on centiloid scale in complete amyloid clearance. This cutoff value is defined as the 24.1 centiloids. In this study, also participants, it was found that participants who achieved an amyloid load of 11 centiloids or less at week 24 after the initial of treatment and discontinued treatment, the median time to the reaccumulation of amyloid to reach from the value 11 to 24.1 was 3.9 years. Of course, these results are coming from a limited number of patients, and it remains to be validated in the next years if something changes or these results will be duplicated in the future studies. At this time, I want to thank you for your attention and wish all of you a summer holiday. And if there are any questions, any comments, what would you like to discuss?
Okay, thank you, thank you a lot, Professor Valotaschi, for this thorough presentation. I don't know if we have any questions from the audience or from Dr. Datseris.
Thank you for your talk, Varna. One simple question. There are many efforts, not only in our scientific community, but also in biochemistry to find the proper biomarker for the early diagnosis of Alzheimer's disease and amyloid plaques or tangles. What do you believe? Which will be the winner of this competition? Us or the others?
I think that this will change in the future because, okay, it may be more easy and I don't know the cost, of course. I don't have such information about the cost, the use of blood or CSF biomarkers. Maybe they can detect changes early because it is, let's say, more easy to undergo a blood test to see if there is beta amyloid accumulation than to perform amyloid PET. But if we think that, if we have in mind that regardless of the biomarker used for the establishment of the disease, nevertheless, the response to treatment demands amyloid PET. And this makes it logical to have a baseline PET to compare. We can't compare parameters which are not the same. It's not we cannot compare the results of a treatment based on amyloid PET and centiloids and so on with blood biomarkers or CSF biomarkers and the amount, because the first findings from the use of blood biomarkers is that okay, we can detect the disease early and easy with an easy procedure, but there is no change. Please correct me if I make a mistake. We don't have the information from blood biomarkers after treatment about the response to treatment. So I had recently a discussion with a neurology professor who told that he will proceed with the treatment in 2 patients using CSF or blood biomarkers, but he needs to perform amyloid PET for the evaluation of a response to treatment. So we have to compare similar parameters, similar methods. And I think that the role of biomarkers may be complementary. And maybe we can use a CSF or blood biomarker, and we have, if they are positive, they must proceed to amyloid PET to establish, to make the establishment of the disease.
Okay, I agree with you because, okay, CNF markers or plasma markers are extremely sensitive, but at the end of the day, you have to see it to believe it. And we provide the seeing. And thus, I believe that we'll win at the end of the day. So thank you. Thank you all. And
Thank you
let's
once
move to
again.
the next speaker. Thank you, Vanna.
Okay, thank you very much,
Thank
Professor
you.
Valotasiou, for this thorough presentation. And let's move at the next one, the presentation of Dr. Evangelia Skoura. Dr. Skoura is a nuclear medicine physician and Deputy Director of Nuclear Medicine Department and Head of PET-CT at Henry Dunant Hospital in Athens, Greece. So let's hear Dr. Skoura.
Good afternoon. I'd like for the kind invitation. I'm sorry that I'm not there. I apologize. In the next minute, I'm going to present my lecture with the title Illuminating Inflammation, Emerging Role of PET in Autoimmune Encephalitis and in Pyeloneoplastic Neurological Syndrome. A very interesting but also difficult subject. Let's start with Pyeloneoplastic Syndrome. It's a group of pathological conditions characterized by a variety of clinical manifestations observed in patients with malignant neoplasm and whose manifestations are not related to the antibody disease of the tumor or its metastasis. The frequency varies depending on the type of cancer and the state of the disease. They may occur before or after diagnosis of the neoplasm. More common with pyeloneoplastic syndromes in blood cancer, breast cancer, malignancies. They can check with symptoms, neurological, endocrine, through non-immune mechanisms. The mechanism have endocrine like hypercalcemia, hypertension of antidiuretic hormone, production of immunoglobulin. They occur after diagnosis of cancer. As a rule, they subside with the treatment of the neoplasm. And not immune mechanism. And then we have neurological, dermatological, rheumatological, in infancy, they occur before the diagnosis of cancer. They often do not subside with the treatment of the neoplasm. An interesting review from 2025 said that pyeloneoplastic syndrome is the result of an immune response against certain onconeural antigens or abnormal release of mediators such as hormone, cytokine, and peptide. Plastic syndrome, neurological and non-neurological, their disease can be different and that is a valuable diagnostic tool for detection or exclude pregnancy. The additional article that we use in this case is known as the post analog, non-specific soldier. It is increased glucose metabolism, and you can see malignant cells, inflammatory. Let's see in pyeloneoplastic syndrome. When malignant your MR in infected lung with a positive predictive value, negative value, specific it also examination malignancy nervously and it when antibodies are negative. So it identify the site of malignancy, right, where it's traveling, and also help the therapeutic like ataxia has specific antibodies. And as you can see, so as primary tumor, it was a small, also neurological neoplastic syndrome. Because of that, sometimes the diagnosis is different. So have, can have it in children with nervous better stimulation, chocolate syndrome, and negative neuritis. Peripheral killer syndrome, and autonomic neuropathy, neuromuscular infarction and muscles, Laborton myasthenic syndrome, dermatomyositis, polymyositis, and their accurate and rapid diagnosis is often difficult due to the heterogeneity of symptom presentation. Mild mental optimism, when there are diabetes, some diabetes are fully characterized, while others are only partially characterized and need further investigation. During the vaccine response can be used as a diagnostic method. They arise due to the shared connection between the cell and neuronal structure. We can have a neuronal antibodies such as AD2, AD2, ADA, which are detected in serum or in brain specific type, like MR is normal, also not specific imaging abnormalities. But with but as already said, the cause of the qualitative evaluate the cerebral glucose metabolism and provide complementary anatomical imaging with MR and analysis. G compared to MR. Already said MR is often normal early for this in about percent of the normal. We have the different metabolism. There is the hypometabolism, most common finding, and hypermetabolism. Usually have it in hypermetabolism. Usually have it in basal ganglia, hippocampus, amygdala, thalamus, cerebellum. Here you can see the most common syndrome, neurological syndrome, limbic encephalitis. Here in PET, we have increased metabolism, as you can see in temporal lobe. We have pyroblastic cerebellum degeneration. Here, in the beginning, in the early stage, you have increased uptake, and at the late stage, we have decreased uptake. And here again, a better table. You can see the syndrome. You can see the antibodies that we could have and help us for the diagnosis, not us, the neurologist. And also the PET-CT finding, as you can see, pyroblastic limbic encephalitis. In PET, we have medial temporal lobe hypermetabolism. But also I want to tell you that even when we don't have brain abnormalities, like in opsoclonus myoclonus, like Lambert-Eaton syndrome, PET can help because it can recognize where is the primary malignancy. And as you can see, small cell lung cancer, it's the most common malignancy. In paraneoplastic limbic encephalitis, you can see an example here. There is increased uptake in the medial temporal lobe, mainly the hippocampus and amygdala, and the sensitivity of PET-CT is high, is 80 to 90%. In cerebellar degeneration, also here it can help in the acute phase. We have hypermetabolism, and in the chronic phase, hypometabolism. In opsophlonus myoclonus, FTG PET can detect malignancy in the thorax or breast, but here also PET-CT with gallium DOTATOC can help, as when there is a neuroblastoma in children, opsophlonus myoclonus could be a paraneoplastic syndrome. In Lambert-Eaton, PET-CT can detect the most common type of primary malignancy, that is small cell lung cancer. But also we have other syndromes that have no antibodies, autoantibodies. The seronegative paraneoplastic syndromes. There we have symptoms due to an immune response against an unknown cancer. Paraneoplastic antibodies are not detected in blood or CSF, and they often involve the nervous system. We have to remember that the presence of antibodies is not a prerequisite for performing an PET-CT. However, the presence of antibodies increases the likelihood that PET-CT will detect an underlying malignancy. PET-CT it's very important that can detect tumors at an early stage that are not visible with conventional imaging methods. And in seronegative syndromes, even in the absence of antibodies, PET-CT maintains high sensitivity, 75 to 80%, for detecting malignancies in patients with clinical suspicion of a paraneoplastic syndrome. Neurological patterns in the brain, PET-CT may reveal specific patterns that can help and can be a diagnostic biomarker of the disease, even before the structural changes appear on MR. Another condition is autoimmune encephalitis. For us, nuclear medicine physicians, it's not very known, but I think that we have to learn about it because neurologists ask PET for this entity. So, autoimmune encephalitis is a serious condition where the immune system attacks the brain, causing inflammation that can lead to neurological and psychiatric symptoms. It is usually mediated by autoantibodies targeting neuronal surface or intracellular antigens. In some cases, it could be paraneoplastic, but also we have the seronegative autoimmune encephalitis, that is even more difficult diagnosis to be performed. In this seronegative autoimmune encephalitis, there is no identifiable pathological antibody, either in CSF or serum, and the absence of these antibodies does not mean that the disease that is not present, but may indicate either the existence of unknown antibodies or mechanism that cannot be detected with current methods. In autoimmune encephalitis, the symptoms vary and may include cognitive impairment and memory problems, psychiatric disturbances, seizures, neurological deficits, and even more severe symptoms requiring urgent medical intervention. The diagnosis is difficult. The neurologists have the clinical evaluation, detailed medical history, neuroimaging like MR, EEG, but after that they need FTG PET-CT. I'll present you some interesting studies about this autoimmune encephalitis. The first one from China. They wanted to investigate a diagnostic, a predictive role of PET-CT in patients with autoimmune encephalitis as a whole group, both antibody positive and antibody negative. As you can see, about 69% had positive antibodies. Here it's the different clinical symptoms and the different antibodies that there were. PET-CT seems to be more sensitive than MR, as only 37% of the patients had abnormal brain MR versus 94.3% that had abnormal metabolism patterns in PET. The detection rate of PET was about 91% in patients with normal MR. Usually the patients had mixed metabolism patterns, hypermetabolism in cerebellum, basic ganglia, medial temporal lobe, and hypometabolism in frontal cortex and occipital cortex. And they concluded that PET-CT was more sensitive than MR to detect neuroimaging abnormalities in autoimmune encephalitis. From this study, some cases, some patients, you can see with red the increased uptake, and the blue or green the decreased uptake. And here is a sum of all the patients. And you can see the increased uptake here, and also blue or green, the reduced uptake. Another interesting study showed that PET-CT is the most sensitive tool in the diagnosis of autoimmune encephalitis, as PET-CT had findings in 85% of the patients with seronegative and seropositive autoimmune encephalitis. Pathological CSF results only 62%, MR 40%, and EEG 30%. And another interesting publication, they show that using the cortex striatal metabolic ratio could be a marker for differentiation of autoimmune encephalitis from controls group, as the mean metabolic ratio was significantly lower for autoimmune encephalitis patients than for healthy subjects and than for MCI patients. And this is an algorithm, diagnostic algorithm for autoimmune encephalitis from neurologists. You can see the step 1, confirm focal or multifocal brain pathology suggestive of autoimmune encephalitis. Step 2, confirm inflammatory etiology and rule out competing possibilities. And step 3, screen for associated neoplasm. Let's see where PET can help. In the first step, in order to confirm the presence of encephalitis, PET-CT could be used when, in cases of high suspicion of autoimmune encephalitis, when MRI is negative and there is clinical uncertainty, or when MRI is contraindicated. PET-CT has higher sensitivity than MR and can reveal brain abnormalities at an early stage of the disease. And there are specific common findings patterns: bilateral temporal hypermetabolism and bilateral hypometabolism in the occipital and or parietal lobes. And step 3, screening for associated neoplasm. We've already said that the most common neoplasm associated with autoimmune encephalitis are small cell lung cancer and also thymic neoplasm, breast cancer, ovarian teratoma or carcinoma, testicular seminoma or teratoma, neuroblastoma, lymphoma. And whole body PET-CT can help because it's more sensitive in early stages when other imaging is negative or inconclusive. And it can also be used as an initial screen when there is contraindication to diagnostic CT with contrast agent. And finally, which is the protocol that we have to use for brain imaging with FDG PET-CT for these cases, these neurological conditions. The preparation, fasting for 6 hours at least. Only water is allowed. discontinuation of parenteral nutrition or glucose-containing fluids for 6 hours. The patients have to avoid caffeine and alcohol for 24 hours. They have to stay in a quiet, dimly lit room for 20 to 30 minutes before the tracer administration. There is instruction to keep eyes open during the waiting period. After the administration, there is a resting uptake period for another 45 to 60 minutes, and the imaging is 5 to 20 minutes, depending on the protocol that each center used. Thank you very much.
So, thank you, Dr. Skura, for this excellent presentation. And this is the end of the first part of this scientific program. So let's have 25 minutes break, and we will be back in a while, in 25 minutes. Thank you.
Dear colleagues, good afternoon
το
to
δεύτερο.
all, those from home and here. It's a pleasure to join this meeting, especially this session regarding nuclear cardiology. We have distinguished colleagues who gonna share their knowledge and their experience in the field of nuclear cardiology. We're going to discuss about the developments and the new technology in myocardial perfusion imaging. And without delays, we move to our first speaker, is Dr. Papandoniou, who is consultant at Rikos Dinan Hospital. Who's going to speak about difference in the pharmacologic stress agents and when and how to use them.
Okay. Good afternoon, everyone. It's a great pleasure to participate in today's event about best practices and tips in nuclear medicine. Over the next minutes, we will discuss an essential part of our daily clinical practice, pharmacologic stress agents. We will analyze their differences, their mechanisms of action, and most importantly, when and how to choose each one, ensuring both safety and excellent diagnostic quality. So the question is, why do we need these drugs in the first place? We know that treadmill exercise is the gold standard. Unfortunately, up to 50% of patients presenting for myocardial perfusion cannot reach their target heart rate, whether due to mobility issues, age, or respiratory problems. For these patients, pharmacologic stress is not just an alternative, but a necessity. It allows us to induce the required coronary hyperemia or increase the cardiac workload in a safe and controlled manner. Let's look now at the big picture here. When we induce pharmacologic stress testing, the agents at our disposal are fundamentally divided into two main physiologic categories, based on whether they manipulate blood supply or myocardial oxygen demand. First, we have vasodilators, which work strictly on the supply side by directly or indirectly relaxing coronary smooth muscle to increase blood flow. Within this group, we subclassify them based on their receptor precision. We have the older ones, non-selective agents like adenosine and dipyridamole that flood multiple adenosine receptors to induce hyperemic flow. And we also have the newer selective agents like regadenoson that target the A2A receptor, maximizing our diagnostic hyperemia while significantly minimizing systemic side effects. Crucially, vasodilators don't usually cause true ischemia. They reveal coronary artery disease by exploiting flow heterogeneity and by unmasking differences in relative blood flow between healthy and obstructive vessels. Secondly, on the completely opposite side of the spectrum, we have inotropic and chronotropic drugs, primarily represented by dobutamine. Dobutamine does not cause direct vasodilation. Instead, it stimulates cardiac beta receptors to actively increase heart rate and contractility, closely mimicking physical exercise. By forcing the heart to beat faster and harder, it drives up oxygen demand to elicit true functional ischemic endpoints. Understanding this clear division between altering supply via blood flow and generating demand via contractility is vital because it dictates us exactly which agent we should select for a given patient's clinical profile. Now that we have separated our tools into vasodilators and inotropes, let's dive into the exact molecular mechanics behind direct vasodilation. To truly understand how these drugs work, we have to look closely at the receptor targeting. Our primary clinical target is the A2A receptor pathway. When an agonist binds to the A2A receptor on coronary smooth muscle cells, it triggers a cascade reaction that increases the intracellular cyclic IMP, This causes smooth muscle cells relaxation, expanding the coronary arteries and producing a 3 to 4-fold increase in myocardial blood flow above baseline, giving us the perfect hyperemic window required for high-quality imaging. The clinical challenge with all their non-selective stress agents is their complete lack of precision. They cannot separate the A2A receptor from its siblings, meaning they simultaneously stimulate the A1, A2B, and A3 receptor, resulting in a wave of unwanted systemic side effects. The current trend in nuclear cardiology is to prioritize absolute A2A selectivity. Newer stress agents improve patient comfort while elevating the overall safety profile in our labs. Let's have a quick look now at the receptors we talked about. A1 receptor is found on the AV node. Its activation slows down conduction, which is why older drugs can trigger AV blocks. The A3 receptor is located on mast cells and bronchial smooth mast cells. Stimulating it causes bronchoconstriction. And the A2B receptor is responsible for peripheral vasodilation and intestinal smooth muscle contraction, contributing to that intense sensation of flushing and abdominal discomfort. Moving on, let's talk about adenosine, which had been the gold standard in clinical practice for years. It's an endogenous nucleoside characterized by an ultra-short half-life of less than 10 seconds. This rapid clearance means two things for us. Firstly, it requires a continuous intravenous infusion using a pump, dosed at 140 micrograms per kilogram per minute for 6 minutes. Secondly, the radiotracer must be injected precisely halfway through the infusion at the third minute. This ensures that the radiotracer circulates and binds while the myocardium is under steady state maximum hyperemia. The main red flag now of adenosine comes from its non-selective nature, as it stimulates A1, A2A, A2B, and A3 receptors simultaneously. Because of this, adverse effects like chest heaviness, dyspnea, flushing, or even AV blocks are common during the test. However, its greatest advantage is that once we turn off the pump, the side effects resolve almost instantly. This gives the physician excellent control over patient without necessarily needing to rush for reversal agents like aminophylline. Lastly, a quick practical reminder. Because caffeine is a competitive antagonist of these receptors, avoiding caffeine for about 12 to 24 hours prior is critical to prevent false negative scans. These limitations of non-selectivity is what drove the industry to develop newer, more targeted A2A selective agents, which we will discuss shortly after. We will examine now two alternatives to standard adenosine, dipyridamole and dobutamine. These two agents represent different pathways to achieving stress in myocardial perfusion imaging. Let's start with dipyridamole, which has an indirect action. Instead of binding directly to receptors, it blocks the cellular reuptake and metabolism of the patient's own endogenous adenosine, thereby elevating its levels. It is infused over for minutes, but here is the critical clinical differences. It has a much longer half-life of 30 to 45 minutes. Unlike adenosine, if the patient experiences severe side effects, simply turning off the pump will not resolve them. This requires careful extended patient monitoring, which makes the administration of aminophylline common to reverse the effects. On the other hand, we have dobutamine, which is our ace in the hole when the direct vasodilators are contradicted, most commonly in patients with severe asthma or bronchospasm. Dobutamine is a synthetic catecholamine, a beta agonist, which it is administered via a dose escalating protocol, starting low and going up to 40 micrograms per kilogram per minute. The mechanism here is entirely distinct. While vasodilators induce a harmless flow heterogeneity to unmask coronary disease, dobutamine actively mimics physical exercise. It forces the heart to work harder, increasing myocardial oxygen demand and relying on the true ischemic endpoints. This brings us to the present day and to the agent that truly revolutionized the workflow in modern nuclear medicine departments, regadenoson. It is a highly selective A2A receptor agonist by specifically targeting the A2A receptors on coronary smooth muscle cells. It triggers the necessary coronary vasodilation while successfully avoids the systemic side effects. This makes it a much safer and highly tolerated option, even for patients with asthma or COPD. But apart from this, its absolute huge advantage is its unparalleled ease of use. Unlike other protocols, it is administered as a single pre-filled fixed dose bolus of 400 micrograms, regardless of the patient's body weight. The protocol is rapid. We give this bolus for about 10 seconds, which is followed by saline flush. And after that, after 10 or 20 seconds, we inject the radio tracers. So regadenoson has transformed pharmacologic stress testing into a fast, highly reproducible, and patient-friendly protocol. As you can see here in this chart, a striking visual representation of the receptor affinity and selectivity profiles is provided. Regadenoson dominates the field when it comes to A2A receptor selectivity. Adenosine, on the other hand, hits everywhere. Look at this table now. It serves you as a comprehensive summary and a highly practical guide for a daily clinical practice. It shows us the core parameters we manage in the stress lab, method of administration, half-life, and the respective antidotes. When you look at this data head-to-head, a few critical clinical relationships stand out immediately. First, notice the direct connection between an agent's half-life and how we use its reversal agent. For adenosine, who has a very short half-life, less than 10 seconds, it's not used any antidote. Secondly, look at the contrast in operational workflow. 3 out of 4 agents demand weight-dependent math and timed infusions. Regadenoson simplifies this with its fixed bolus dosage. Finally, dobutamine, which drives stress through adrenergic catecholamine stimulation, aminophylline is ineffective. We rely strictly on beta blockers, specifically ultra short-acting agents like esmolol. Now, knowing when not to give a drug is the most important tip of the day. For vasodilators, absolute contradictions include second or third degree AV block without a functional pacemaker, profound sinus node dysfunction, blood pressure less than 90 millimeters of mercury, active wheezing, or recent caffeine intake. Conversely, dobutamine is contradicted in recent acute myocardial infarction, unstable angina, uncontrolled life-threatening arrhythmias, severe hypertension of RLBBB, which can cause false positive septal defects. Let's now tie everything we have discussed so far into a practical clinical decision algorithm. Firstly, when accessing a patient with severe asthma or COPD, non-selective agents like adenosine and dipyridamole are completely off the table. Regadenoson is an option only if the patient is totally stable and without wheezing. Secondly, for patients with LBBB or pacemakers, we must completely avoid physical exercise and dobutamine. Finally, we regularly face the issue of recent caffeine consumption. If the patient can have physical exercise, we can switch to treadmill, or not. If not, we can reschedule the exam. Let's see now how we manage the side effects. If a patient experiences severe side effects like severe hypotension, persistent chest pain, prolonged AV block, we must step in immediately with our established antidote, the aminophylline. Aminophylline functions as a competitive adenosine receptor antagonist. It displaces the vasodilators from the tissue receptors, providing an immediate relief to the patient. One vital clinical rule to remember is the one, unless it's an extreme emergency, always ensure that aminophylline is administered 1 to 2 minutes after the radio tracer has been injected. This allows the myocardium enough time to trap the tracer under maximum hyperemic condition, preserving our image quality. Here we are now. This slide highlights what I consider to be one very good clinical tip in MPI techniques today. It's the combination approach. Whenever a patient is physically capable of light exercise, we should always look to supplement our vasodilator protocols with low-level exercise. This achieves three highly critical goals. First, it reduces the vasodilator-induced side effects. Secondly, it reduces the splanchnic radio tracer uptake. And last, it improves the image contrast. I have to emphasize one last thing. We never use this combination approach in patients with LBBB or pacemaker, which causes artifacts in septum. In closing, we could keep in mind that the ideal pharmacologic stress agent is the one that maximizes coronary hyperemia, while it minimizes the side effects and keeps the procedures not complex for both patient and also the doctor. Thank you very much.
Thank you, John. Is there any questions from the audience or from live stream? I actually have a question for you. It's about a special group of patients. I wonder, is there any preferred stress test for patients with heart transplant?
In patients with heart transplant, without hesitation, the best solution is to use regadenoson, which minimizes all the possible side effects. And this is what it is proposed, regadenoson.
Why do we don't prefer Bruce?
In patients with
heart transplant, yes.
It's also a good question, but the heart is highly sensitive. The transplanted heart is highly sensitive, and I don't think that we should keep it over the edge with Bruce. So? No, it is degenerated. They don't feel anything, but it's sensitive the way it's a transplant. That's why. But yes, it is degenerated.
Opinion, of course.
Denervated.
Can we have
Professor Yannis covered all the things about stress testing. I would like to say that the best for for patients who have a heart transplantation is the pharmacological stress test. It's more safe. This is what you mean. It's more sensitive. And also would like to say what is your opinion about stopping the medication when you use, pharmacological test? What is your, recommendation
For sure,
for sensitivity?
for sure, they don't have to stop the medication about blood pressure. First of all, they should take. First of all, what they have to stop is the beta blockers, and what else? What they have to stop is the diabetic patients should not take
Their medication.
medication. Yes. What else?
Although they don't ask, patients, to stop their medication, it's, better, to stop beta blocker because the sensitivity of the pharmacological stress is higher. But to be honest, I never ask, patients, to stop their medication because you don't know, the whole history, of this patient. So
Of
it's,
course.
so they have, to discuss with their doctor.
Mhm.
But what I asked this question because still, the pharmacological stress, needs, in order to be more sensitive, to stop, the medication, the beta blocker and the nitrates.
Mhm.
Okay. Thank you, John.
Thank you.
We proceed to our next speech. I could not imagine no one else but Maria to have a talk about CZT detectors. She has a very long experience in this modality. So, Maria, we're looking forward to listening to what you'll say.
And at this point, I would also mention that the presentation of Maria Coutelou will be the last one today because of due an urgent issue. Professor Anagnostopoulos can't join us. However, I discussed with him and he is able to provide this very interesting talk about the future of nuclear cardiology in a next scientific event. So Maria has the time, and it's also a pleasure for me because I have also to mention that it's an honor to me, a pioneer in nuclear cardiology, who always honors me with her presence in our scientific events. Maria.
Yes, thank you for your kind words, dear colleagues, dear friends. Good evening. I'm going to talk about the CZT detectors. To be honest, I had, the privilege and the pleasure to use both systems, in Greece, in Onassis, spectrum dynamics, and, in biotricky, I have my Speg. So, you know, I use all these two systems. So I think that I'm very, very lucky in my career. So, cadmium zinc telluride detectors have triggered a paradigm shift in nuclear cardiology, fundamentally replacing conventional analog Anger cameras with state-of-the-art solid-state digital technology. By enabling direct digital conversion of gamma ray photons in electrical signals, CZT systems bypass the need for traditional sodium iodide scintillator crystals and bulky photomultiplier tubes. This engineering breakthrough maximizes count sensitivity and energy resolution, resulting in safer, faster, and highly precise cardiac and whole body imaging. Clinical evidence demonstrates superior performance in detecting a hemodynamically significant coronary artery disease compared to traditional SPECT, coupled with quantitative assessment of myocardial blood flow and flow reserve, which strengthens risk stratification and prognostic capability. This technology supports personalized clinical management through improved detection of subclinical ischemia and protocol optimization for radiation reduction. The first time we used, cardiac dedicated gamma cameras for cardiac imaging, and now also we have the cameras for the general purpose for whole body imaging. Which are the clinical advantages? First of all, we have drastic radiation reduction. It approaches to 70% reduction. It's very, very significant for the patients and also for the healthcare staff. Accelerated clinical workflows in busy departments, we can have a really very fast turnover of the patients. Advanced patient comfort. They have both systems, they have advantages and they have limitations. We can use different positions in order to get the best imaging in order to exclude, to attenuate the attenuation, to have attenuation correction. So we can use either supine or upright position in this spec, and in my spec, when you use either prone or supine position in order to have better imaging, and also unlocking absolute quantification. For me, this is the best application in gamma cameras, in CZT gamma cameras. It's very important to get non-invasively measurement of blood flow because we can get an accurate and very, very sensitive SPECT perfusion imaging. And myocardial flow reserve, as I had, it's diagnostic metrics previously, which is exclusively to expensive positron emission tomography. We could do this only with PET, which is also the gold standard. But now we can have this, application that we can have this imaging with a dynamic processing using CZT gamma camera. Which are the features of this CZT? First of all, we have stationary multi-pinhole in G discovery. Also, we have equivalent CZT areas in spectrum dynamics. These companies have different characteristics, but both they have excellent imaging. We have to keep this in our mind. It's very nice, to have, these systems in our departments. And also we have 3D full ring systems in Veriton and the G-Star guide in order to have the whole body imaging and to image other organs than the heart. So let's talk about cardiac imaging. Advances in stress imaging protocols are in the camera technology, in process software, which can enhance diagnostic accuracy and reduce also radiation exposure. More advanced techniques help reduce motion artifacts and potentially improve the patient experience due to reduced imaging times. In addition, because contemporary SPECT cameras have made the acquisition of dynamic SPECT easier, quantification of myocardial blood flow and flow reserve is now possible to detect a multivessel coronary artery disease. We have to know in our mind that more than 40% of the patients who experience angina and they go to the cath lab, they have normal coronary arteries. Does not mean they don't have a coronary artery disease. They don't have stenosis coronary disease, but they have microvascular disease. It is an issue which, in the past, we thought that we had false positive results. It's not this, the answer. They had problem, they had microvascular disease, they had angina, they have angina, and they had a positive myocardial perfusion imaging. So in order to get an accurate SPECT myocardial perfusion imaging, we have a high quality imaging. We have center approach. These cameras are cardiocentric, they focus on the heart. We achieve optimal results, which means that we have excellent outcomes. If we have excellent results, it means that we answer the clinical question, which cardiologists have, and the patients have excellent outcomes. And also we have other technological innovations in hardware and software. And as Jan said before, we have also many stressors in order to have all this in our departments. What I said, we need to have, in order to have a good imaging, we have to have, now we have long image acquisition, we need, less. We have low image resolution within the current systems, and we have also radiation dose to the patient, to personnel. all of these problems we can solve with the CZT gamma cameras. I talk about this. I'm not one. So, as I said before, nuclear cardiology has rapidly evolved over the years. Increased photon sensitivity through the addition of high sensitivity collimation and multi-detectors. We have improved energy resolution, which with today's solid state detectors made the cadmium zinc telluride CZT gamma cameras, which has 10 times higher sensitivity than the conventional gamma cameras. Many advantages compared to the traditional gamma cameras, allowed for reduced radiotracer dose and radiation exposure and decreased acquisition time. The patients are really happy. Instead of being on the table for 18 or 22 minutes, they stay for 6, 7, 8 minutes. It depends on the body weight. And so we have technological innovations in hardware and software, which help to improve imaging quality and diagnostic accuracy and reduce radiotracer dose. It's very important to have in our mind that it's not allowed to have more than a small percentage of myocardial perfusion imaging, which we are not satisfied. With these cameras, we overcome this problem. So the major advantage of these cameras is that they can determine locations with complete certainty. It's very important. We don't have all these problems with the traditional gamma cameras. Apart from CZT, we have other cameras, but I'm not going to stay with this. And here are the two systems, which we have, the spectrum dynamics and discovery in nuclear medicine by G Healthcare. I have the privilege, I have the pleasure, to have experience in both systems, and both have advantages and maybe they have limitations. What do they do? How we get the best quality of imaging? Because instead of indirect process with the current systems, which degrades energy at spatial resolution, we have with the solid state detectors with CZT and the use of special arrangement of many small detectors elements that produce a null or none response to the detected photon events. We have a direct process. We have superior energy resolution, and we have improved spatial resolution and contrast. And if anyone worked, this camera, can understand the difference between these systems. And as you can see to the left, the conventional gamma camera, and to the right, the CZT gamma camera, you see the resolution, how much better quality we have at contrast. And here are the systems, not only for cardiac imaging, also for the whole body imaging, for both companies, which are the Veritone and the G-Star Guide camera. And here is the MyoSpeg, which we have now in Bioiatriki. And as you can see here, we have an excellent, really imaging. It's much more different, with traditional gamma cameras. You have, to get more familiar with the new, system, because the walls are thinner, are more clear, and you see, small defects, and you have to, to get used, with these images. But really, if you start, working with these cameras, you don't want to go back. And here is the crystals, the detectors of CZT. Here are the two systems, as I said. And as you can see here, we have eccentric imaging, with improved detector technology, the collimator design. So we have sensitivity higher, we have energy, a better energy discrimination. We have compact design with one type of the camera. On the other one, we have a better positioning and more easy for the patients. Here is the difference between the detectors with the current system and the CZT. And as you can see here, we have improved sensitivity and resolution when we compare with the conventional gamma cameras. We have a really higher sensitivity, 4 to 8 times more than the conventional systems. As you can see here, Okay, as you can see here, we have a higher speed spec sensitivity with, the CZT compared to the conventional for both stress and the rest imaging. You see, we have great difference between the traditional and the CZT gamma cameras. I don't want to stay more in this. So this SPECT cardiac imaging system can complete a gated SPECT study in only 2 minutes. This is significant improvement over current technologies that are required 12 to 20 minutes. This incredibly fast, high-quality acquisition can be achieved through the optimized features of broad view technology in the DSPECT. The same results you can get with MyoSpec. We have speed, we have less time, for acquisition, and the patients are really very, very happy when they perform the exam. And as you can see here, we have an excellent quality of imaging. If you compare for conventional cameras and CZT. For iodide and also for a technetium. And here you can see from a Discovery nuclear NM530 camera, we have a stress of 2 minutes and 4 minutes for rest. Very, very, very short times for the acquisition, so that the patients, they feel very, very comfortable. It's really very, very efficient, this system. And here is from my patients. As you can see here, stress only. In a patient with a BMI 38, he's very obese. And as you can see here, he underwent stress only because it was normal. The perfusion was normal with CZT. So we have excellent even in obese patients. So it's better to do first stress and then rest. And if stress is normal, then we use only the stress only protocol, and they achieve only a 1 millisievert radiation dose in CZT gamma cameras. So we achieved very low reduction in radiation dose. So the patient lies comfortably. We have less radiation staff and cost savings. And we can get attenuation correction techniques either by supine and, how can I say, supine and, yes, no, supine and upright position, either prone or a supine position with the other system. So we can use without having CZT to get excellent quality of imaging. And abnormal stress first has been shown to have excellent prognosis compared to normal rest stress imaging. So it's they use only in other countries. They prefer to use first rest and then stress, but it's much more better, to get the stress first image. So we have clinical and workflow benefits. We have faster results. We have image quality. We have dose reduction. We have simultaneous multi-isotope imaging, and we have patient compliance. So many, many benefits for the patient. And here, a very excellent image with MyoSpect gamma camera. It's straight to the heart of the matter. It's really very, very excellent images. And what I want to mention and to keep in our mind is that we have the possibility to have myocardial blood flow, myocardial flow reserve. This is very important because it detects microvascular dysfunction, facilitates the diagnosis of a multivessel coronary artery disease, and describes changes between 2 studies in the same patient. We know that myocardial blood flow with PET is the gold standard. And also I can say that myocardial blood flow and flow reserve with this spec is really comparable with the values which we get with PET. Tell me about the time. Do I have time? Okay. So what is myocardial flow reserve? Which is the definition, reflects the amount of additional blood flow that can be supplied to the myocardium above resting or baseline blood flow levels. In other words, when there's a limited or lack of myocardial flow reserve, this suggests an inability to further increase myocardial blood flow due to the maximum vasodilation of a stenotic vessel. What we use, these are the tracers above the line for PET tracers, and underneath is, for dynamic spec. And according to the American Society of Nuclear Cardiology, the guidelines in order to get myocardial blood flow and myocardial flow reserve is that is more useful for patients with no prior history of cardiac disease who present with symptoms of myocardial ischemia, patients with known coronary artery disease who may need more specific physiological assessment. And keep in mind, now, all the guidelines say that we don't go for the anatomy, we go for physiology. So we don't care about the anatomy, we care about the physiology. And this is the benefit, the advantage of nuclear medicine, because we see physiology, not anatomy. And identifying suspected multivessel coronary artery disease, assessing microvascular dysfunction when there is a disparity between visual perfusion abnormalities and normal coronary angiography. Heart transplant patients with potential vascular abnormalities, as Adigonis asked before. Although somewhat empirical, American Society of Nuclear Cardiology imaging guidelines suggest that myocardial flow reserve values greater than 2.3 indicate a favorable prognosis, and values less than 1.5 suggest significantly diminished flow reserve and elevated cardiac risk. And here are the protocols. I'm not going to stay. And here's our exams. As you can see here, we have through two vessel disease, and we see that global coronary flow reserve is very, very low, is 1. So this patient has, in the most territories have normal perfusion imaging, but the coronary flow reserve is abnormal in all territories. So it gives, a great advantage, to the patient. And here, what we do, we see the kinetic of the tracer of the different compartments of the heart, and then the uptake of the myocardium. This is the way, we use the dynamic studies. Here is an example from Onassis Hospital. And as you can see here, we have a normal coronary flow reserve in one patient who have the normal coronary arteries. And here we have an abnormal study. And as you can see here, we have in circumflex, less than 2, the coronary flow reserve, the patient had a stenosis of 70%. So he underwent catheterization. He had a not very significant stenosis. He came to our department. He underwent myocardial perfusion imaging and dynamic study, and the coronary flow reserve was decreased. So again, he went to the cath lab and he underwent PTCA. So we helped, the cardiologist in order to manage the patient the best way. Okay. I don't want to stay. I want to say the sensitivity with FFR, with CZT, and compared to PET. And as you can see, we have really good results with a PET, with a SPECT dynamic study. And here, a patient with a high BMI, and as you can see here, we have a normal case, as I said before. So, and to the right, we have a patient who underwent with low dose, and as you can see, we have an excellent imaging and normal perfusion imaging. And here are the general purpose for whole body imaging for both companies, Spec Dynamics and DG. And as you can see, we have excellent imaging images. You can see here from Veriton, the same also for G Star Guide, and a review on 2016 by the European Association of Nuclear Medicine assessed the performance of Speg CZT imaging in coronary artery disease. He compared the dynamic with oxygen in the water day study. So if I want to conclude, advantage of CZT camera is that we have a dark digital conversion. We have superior energy resolution. We have exceptional spatial resolution. We have higher count sensitivity, even more than 5 to 10 minutes, and we have low radiation and faster scans. And also reduced lifetime radiation, faster scanning for fragile patients, as Yanis mentioned before, for patients who have heart transplantations, and also a new window is in theranostics, as you can see here in that paper. We have performance study on CZT gamma camera for monitoring lutecio PSMA treatment. So we use these cameras in oncology for micro lesion visualization, for high precision theranosis and target therapy. We have advanced isotope quantification. We have multi-isotope imaging. And our goal as a community is to provide non-invasively effective, efficient imaging protocols in order to maintain consistent and high-quality studies. Recent technical CT cameras with measurements of myocardial perfusion and myocardial blood flow reserve and new radiopharmaceuticals as fluoride and pharmacological stress test agents as regadenoson. These advances continue to expand the role of nuclear cardiology for the accurate diagnosis and prognosis in patients with known or suspected coronary artery disease. The recommendations to the International Society of Atomic Agency recommends that we have to use protocols that with less than 9 millisieverts. And with this camera, we achieve less radiation dose in all patients. Here, attenuation correction by different positioning. As I said, in a patient with BMI of 42, as you can see, we have an inferior defect in the first row. And when we get images in a different position, we have a normal perfusion imaging. And which are the future directions for imaging? First of all, PET has high count statistics, as we know, and high temporal resolution, robust attenuation correction, and excellent extraction characteristics. The introduction of solid cameras have made the rapid dynamic acquisition of the input bolus possible. However, the lack of attenuation correction, the relatively poor extraction fraction of current Speg flow tracers continue to pose challenges. Speg myocardial blood flow with technetium STAMIBI correlates very well with disease severity and differentiates non-obstructive to obstructive disease measured with FFR. Myocardial blood flow respected PET using ammonia or rubidium and water are really the gold standard. Is current technology ready to support future development? I think that the answer is clear because we have precision, we have efficiency, we have versatility, and the future also of theranostics. So we have to use the right test at the right time for the right reason and to do this with the right way. Thank you so much for your attention.
Maria, thank you for your insightful presentation. Any questions from the audience?
From the chat, something? No?
Okay. I'd like to ask, just because I'm curious and nothing else, for CCT camera, do you prefer supine or upright position? If you had to choose, I mean.
For this Speg, you mean? For this Speg. I prefer upright position.
Upright.
Unless, I have, problem, then, I prefer, supine.
Okay.
Yeah. It's better because you don't have, the attenuation, you don't have, from the breast problem from the breast.
So you
yes,
have less artifacts,
yes,
you mean?
less, much more less,
Okay.
and also inferior wall.
Mm.
But you have the possibility either with one system or the other system, to overcome these, problems and to get an excellent quality of imaging.
Okay. Thank you.
Maria, you mentioned a lot about the advantages of the new technology and so on. I don't want to go in depth about the debate between SPECT versus PET and so on, since Dinos will have his presentation in the near future. But do you believe that the new technology, CZT cameras, could overlap this advantage of PET versus SPECT?
I don't know if I saw if you saw the slide. Also, the PET systems, and the companies are here. They're using now in order to have to produce PET with CZT crystals. So this is other research. PET is the gold standard. Okay, it's definitely, but the availability is very limited. The cost is very high, and the prices are very high, very expensive. So we have, to use, a regular, SPECT imaging, not regular, the CZT gamma cameras, which have less cost. Is it mine?
No.
Okay, less cost, and they have excellent results and comparable, to PET. So, and also the traces are very, very cost effective. They're not very expensive.
Any other comment or question? So, thank you so much, Maria. And I think that we can close this scientific event. Once more, thank you to all of the presenters, the chairpersons, all of you here with your physical presence, and of course, all the colleagues that were present here via their laptops. And once more, thank you to General Electric Healthcare for their support and Speg Consulting for their technical presence. Thank you so much.
Thank you.